Okay, good morning, everyone. Thank you. We're waiting for the attendees to join in, so we'll give it a few more beats. Thank you. We're just waiting a couple more moments for folks to get on and get settled. Thank you. Okay. It's 10:01. I think we can start. Good morning, everyone. My name is Carol DeAndres, and I'm the Stakeholder and Public Engagement Manager on the Master Plan for Aging team here at the California Department of Aging. Happy to be with you today here for the Alzheimer's Disease and Related Disorder Advisory Committee. Today is November 2nd, 2023, and this is the committee's final meeting for 2023. I know you may be thinking, where did 2023 go? I'm going to go ahead and go over a few logistics for you as everyone gets settled. So let's move to the next slide. Thanks, Rosie. As you can see, here is the Zoom link, and you can join by smartphone, tablet, or computer. To join by phone for audio, here's the audio information. Live captioning is available via the Zoom webinar. And as you can see, we have American Sign Language interpretation. Thank you to Tulip and Trey for their expertise today. We appreciate that. Can you go back? There we go. Thank you. This meeting is in two formats. We have the Zoom virtual format, as well as there is an in-person availability as well, which Michelle Johnston will be the in-person in the meeting room here at CDA. We will be posting all the materials, transcripts, recording of this will be posted on the Cal HHS Alzheimer's Disease and Related Disorders webpage after this webinar. Next slide. We will be having a public comment later in the agenda. For any in-person, you can raise your hand. For our Zoom participants, you can use your raised hand function in the Zoom webinar functions. And for those appearing on the phone, you would press *9 on your dial pad, and in both cases, we would unmute your line. So thank you very much. And of course, we accept written comments at any time. You can put that into the Zoom Q&A. Next slide. Okay, so I'm going to spotlight Derek Lamb.
Hi, good morning, everyone, and thank you, Carol, for the introduction. So I just want to start by saying that we recognize that the new legislation that passed related to Bagley Keene Act, and that's the SB 143 and 544, makes it really easier for people to, and that's us, to participate in meetings, even if they aren't able to travel, include persons with dementia and caregivers. And I would like to have a quick roll call of all the members who are present today, starting with Mac Barron.
Here, present.
Thank you. Dr. Wynn Canio.
Present.
And then Dr. Sarah Farias.
I'm here.
Barbara McClendon.
Here.
Dr. William Mobley. Celine Regalia.
Here.
Andrea Roberts.
Here.
Julie Solier.
Hi, this is Darcy Delgado. I'm covering for Julie Solier as the agency representative today. Thanks.
Thank you so much, Darcy. Dr. Dolores Gallagher Thompson.
Yes, hi, I'm here.
Sally Berkman.
Good morning.
All right, that concludes our roll call. So I would like to turn to the minutes, which has been posted on the website, and just want to see if we have a motion to approve the minutes.
I move to approve.
Thank you, Sally. Any second?
Second.
Thank you, Dolores. Any discussion? All right, all those in favor signal by saying aye.
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 All those opposed?
Aye.
Any abstention? Okay, minutes approved. Before I turn to the next guest, I would also like to congratulate our fearless leader, Susan, on being promoted and appointed to the Federal Advisory Council on Alzheimer's Research, Care, and Services. It's a really, really great honor to have Susan joining us today, not only representing CDA, but also as a member of this Federal Advisory Council. So thank you very much for being here and congratulations.
Thank you, Derek. Thank you.
Right. So next item, I know that Dr. Galy won't be able to join us at this time, but I'd like to ask Darcy to represent him and to say a few words about the topic on recognizing Californians living with dementia and their caregivers. So over to you, Darcy.
You so much. Yes, I definitely don't have a medical degree, nor do I have a master's in public health. So not Dr. Galy, but I am just really appreciative to everyone for being here today. I am so proud to be joining at the start of National Alzheimer's Disease Awareness Month and National Family Caregivers Month. And really, when you think about it, the committee here bridges both of those topics. And today's agenda with focusing on family caregivers is just so fitting for where we are this month and really the numbers that we look at to really understand the scope of this issue. And, I was reviewing some of the numbers in preparation for being here today. And one of the things that really stood out to me, and I know will be a topic of today's discussion, is caregiver health. And the percentage of caregivers who in and of themselves are facing chronic health conditions, facing depression, facing behavioral health issues, it really just compounds. I know we are incredibly focused on individuals in California who have Alzheimer's, who have other dementias. And when you think about the scope of those individuals and then the caregivers that are struggling both with those that they are caring for and their own health and mental health issues, it just really emphasizes the importance of the work that this group is doing, that this committee is doing, to really ensure that those topics stay front of mind for state policymakers. And so I just really appreciate you all for serving in the roles that you serve and to this collective committee, because the breadth of your experience and your deep, deep understanding of these complex issues related to Alzheimer's, related to dementia, and related to caregivers is just incredibly important for this administration and for California Health and Human Services Agency. And it was also pointed out to me that this might be one of the longest standing advisory committees in our agency. And having been created in the 1980s, really prepares us for this exact moment. Close to 800,000 Californians are living with this disease, with over 1 million family members providing care. And so thank goodness that this group is around to help keep these issues forefront, because frankly, it's something that all of us are experiencing. When I was reading through the agenda, was thinking about my own 70, probably he would not want me to say this, but probably 75-year-old father who's caring for my 95-year-old grandmother, who he himself struggles to get him to the doctors. And oftentimes when I think and worry about some of the physical ailments that he has, let alone as a caregiver himself. So just know that, you know, all of the personal experiences that you bring to this committee are incredibly impactful for the discussions and the decisions that are being made. And I'll tell you, at least the Delgado family thanks you for the work that you're doing, because it is really far-reaching. A couple of things that I just want to point out, hopefully they will come up today, but very proud of our nation-leading Dementia Care Aware initiative, the direct care worker training and stipend programs that are put out by both Department of Aging and Department of Social Services are multiple efforts that I just want to highlight as work that policy work and programming that comes straight out of decisions and recommendations that come out of this committee. So just very thankful for that and wanted to lift those up as good practices and highlights that connect to the work that you all do on this committee. I also want to highlight, you know, we touched on behavioral health issues, but as common knowledge now is that we aren't in the best budget situation. We don't have the fiscal windfall that we maybe had 3 or 4 years ago within the state of California. But despite that, last year, Department of Aging was given $50 million for their older adult behavioral health initiative. So $50 million, I told Susan yesterday, I can probably count on one hand all of the new initiatives that were funded last year. And this was really just one of very few, but really emphasizes this administration's focus on behavioral health and recognizing that behavioral health issues are huge for the older adult population. In my previous life, I was a psychologist, and when you look at the statistics of the comorbidity between dementia and depression, or dementia and anxiety, it really is incredibly high. Those two go hand in hand. And so understanding that we have those dollars to really focus on behavioral health issues for older adults. I know a large portion of that will be going out to local community-based organizations to help tackle some of these issues. So lots going on, but just to close, I want to acknowledge and thank again the unprecedented partnership amongst our agency directors, the department directors, and really you, the stakeholders that help inform and drive the decisions that our departments are making. So thank you all for this work. Really excited to hear all the content for today. And Derek, I think I'll hand it back to you. Thanks so much, everyone.
Thank you so much, Darcy. It's exciting to hear that our great state is paying not only attention to dementia, but also to behavioral health, because indeed these two are very connected. And especially we have seen, a lot of, cases after COVID pandemic started a few years ago. So thank you so much for being here. Next, I would like to invite 8 esteemed panelists to talk about a subject which is very close and dear to our heart, and is on supporting unpaid caregivers of people living with dementia. So to start our discussion, I would like to welcome Dr. Angela Chi, who is a research scientist with the California Department of Public Health, and she's going to talk about California's behavioral risk factor surveillance system. So over to you, Dr. Chi.
Thank you. Thank you for the introduction. Good morning, everyone. So this morning, I'll be presenting on California caregivers, focusing on those who provided care to family members or friends with Alzheimer's disease, dementia, or other cognitive impairment disorder, using the 2021 Behavioral Risk Factor Surveillance System. So the acronym for that is BRFSS, and I pronounce it as BRFS. So this was the data file that was applied by the Chronic Disease Surveillance and Research Branch. And today's presentation, I will be focusing on just the statewide results and not the county level results due to issues with sample sizes. Next slide, please. Okay, so on this slide, I would like to provide a brief overview of the methodology. So Birthis is the nation's premier system of health-related telephone surveys that collect state data about US residents regarding their health-related risk behaviors, chronic health conditions, and use of preventive services. And Birthis has three components. The first component is the core questions that were developed by the CDC in collaboration with state agencies. The second component is the optional module questions developed by the CDC, but they were selected and purchased by the CDPH. And the third component consists of questions designed by the state to address specific issues that concern the state. For today's purpose, I'll be presenting on the second component, which is the caregiver module. Okay, so moving on to eligibility. So there are criteria that must be met to participate in this survey. Participants must be California residents, be at least 18 years of age, and living in households or college housing. And the way the participants were sampled were through random selections. So there were two sampling frames, which consisted of a list of randomly selected landline phone numbers and a second list of randomly selected cellular phone numbers. So with the landline method, only one member of the household was randomly selected to take the survey for the household. Once a respondent was selected, no other household member could be eligible to take the survey. So for the cell phone method, the person who answered the phone and self-identified as the primary user of the phone was selected to take the survey. Now that we have some understanding on how participants were selected to take the survey, I would like to now present the results. Here's the fun part. In California, we had a total of 2,496 participants responded to the caregiver survey. And of those 2,496 participants, 528 stated that they provided care to family members or friends with Alzheimer's disease or AD, other dementia, or other cognitive impairment disorder, CID, during the past 30 days. Okay, next slide, please. Okay, so before I proceed further, I would like to underscore that all estimates are weighted starting from this slide to the end of my presentation. So as I mentioned on my previous slide, we had 528 caregivers, and that was the unweighted count. Once I adjusted the number with the CDC weight, the new number of caregivers in California was estimated to be approximately 5.4 million. And of the 5.4 million caregivers, 21% indicated that they provided care to family members or friends with AD, dementia, or other CID. And this means that we have an estimated 1.1 million California residents who provided regular care to family members or friends with AD, other dementia, or other CID in the last 30 days. So of these 1.1 million caregivers in California, the majority were older adults, with nearly 41% belonging to 60 years or older age bracket. Next slide, please. Caregivers who provided care to those with AD, dementia, or other CID were 59% females and 41% males. Okay, next slide, please. On this slide, we are looking at caregivers by race and ethnicity. As we can see, this table has asterisks, and that indicates that the data were suppressed for the corresponding category due to issues with data reliability, where the relative standard error, acronym is RSE, is greater than 30%. So RSE tells us how reliable our estimates are. The higher the RSE, the less reliable the estimates. And CDC recommends an RSE of 30% as the cutoff, which means that the only categories where sample sizes were sufficient were the Hispanic and white populations. Almost half of the caregivers identified as non-Hispanic white, and nearly 30% identified as Hispanic. So the takeaway for this slide is that we need to do more to promote the importance of the Birthis survey in the communities where data suppression was applied due to small sample sizes. Okay, next slide. Moving on to the caregiver's household income, an estimated of 32% of California caregivers reported their annual household income levels to be under $50,000. Next slide, please. Okay, so on this slide, we are looking at a bar graph stratified by the caregiver's relationship to the care recipient. The graph is showing that nearly 43% of caregivers who provided care to those with AD, other dementia, or other CID were the caregiver's parents or parents-in-law. 24% were the caregiver's other relatives, so those would be the grandparents, siblings, and sibling spouses. We also have nearly 19% that were the caregiver's non-relatives or friends. So there's one thing that I would like to point out on this slide is this spouse or partner category. That partner is live-in partners, and I think that's important to point out. Next slide, please. 58% of caregivers provided care to family members or friends with AD, other dementia, or other CID for at least 2 years. And of those 58%, 29% provided care for more than 5 years. Okay, next slide, please. Okay, so on this slide, data suppression was again applied to the 20 to 39 hours per week category, which is why there's a missing a graph for that category. The big takeaway for this slide is that nearly 21% of caregivers provided care full-time and more. So that's 40 hours or more to those with AD, other dementia, or other CID. Next slide, please. 63% of caregivers reported that they managed personal care, such as giving medications, feeding, dressing, or bathing for their care recipients with AD, other dementia, or other CID. Next slide, please. 85% of caregivers reported that they also managed the care recipient's household chores, such as cleaning, managing money, and preparing meals. So before I wrap up, I would like to emphasize that caregivers are not only providing care to relatives, but they are also providing care to non-relatives, such as friends with AD, other dementia, or other CID. Next slide, please. Okay, so this slide will conclude my presentation. If you have any questions or comments, please contact the Alzheimer's Disease Program, or you can type in your comments in the comments box if we don't have enough time to take questions after my presentation. You can also find more information about BRFIS on the links provided on this slide. Thank you.
Thank you so much, Dr. Chi. I just want to mention that we have a Q&A session after the last presenter, so which will happen between 11:45 and 12 noon. So with that said, as a proud Aggie, I would like to invite our next speaker, and that is Dr. Janice Bell, who is the Director and Professor Associate Dean of the Betty Irene Moore School of Nursing at UC Davis. And she's going to present on the subject entitled Profile of Caregivers in California Caregiver Resource Center. So over to you.
Thank you so much for the introduction, and I really appreciate this invitation to present some of our findings from the database called CareNav. With my colleague, Dr. Heather Young, I'm a co-PI on evaluation work with the California Caregiver Resource Centers and the California State Department of Aging. Next slide. I just want to quickly acknowledge our team who contribute to this work. They include Jennifer Mongovin, Robin Whitney, Orly Tonkik, Ben Link, and Jessica Famula. So I think there's going to be a presentation a little bit later on by Kathy Kelly describing some of the work of the California Caregiver Resource Centers and the rollout of the technology platform called CareNav. But I'm going to skip right to CareNav and say that it's a cloud-based, HIPAA-compliant client record system. So this is a technology that has been implemented across 11 caregiver resource centers in California, where caregivers can interact with the technology, they can enter their own information, and that begins a process of getting support through the agency. There's a client dashboard that produces tailored information for their specific situation, agency contacts and information, a personalized care plan, secure communications with a care consultant who's most often a social worker. And there's a lot of service use data. So intake and assessment and then reassessment, which is usually 6 months later. And that's the data that we exported for this analysis. So this slide just shows quickly the landing page for CareNav where a person can come in, they can set up an account, enter the portal, and add some of their information. And in the next slide, you see the care model for CareNav, which includes this online assessment, which covers the activities of daily living that the caregiver is supporting, whether they're doing medical or nursing tasks, whether the person has memory or behavior problems, healthcare use for the caregiver and care recipient, comfort with technology use. There's information about insurance and legal documents, paid and unpaid supports, caregiver health status, caregiver burden, which is measured with the Zaret short form 4-item scale. There's assessment of depressive symptoms using the PHQ-9, and then the UCLA loneliness scale to measure loneliness. And the nice thing about this data is that it follows the caregiver as they enter the system, receive support, and then get reassessed so we can actually see if how the program is supporting the caregiver over time. The next slide. So this is a little profile of the caregivers who are served. This includes about 4,000 caregivers. You can see from age that the distribution of age of the care recipients is quite a bit older than the caregivers. So the caregivers, about half are 45 to 64 years of age. And among the care recipients, most are older adults, 65 or above. So this is probably reflecting children taking care of their parents. In terms of gender, more of the caregivers are female. And in the care recipients, the yellow bars of gender, you see those that is a little bit more even. And then this is a diverse group of caregivers and care recipients. So reflecting the population of California really well, just a little over half are white or non-Hispanic, about a third are Hispanic or Latino. And then we have about 8% Asian American and Pacific Islander, and almost 7% Black or African American. On the next slide, some of the characteristics of the caregivers. You see that most of them are not working. There's about 26% that are working full-time and 11% part-time, partly because they're doing the caregiving role and partly because some are older adults. 18% earn below the federal poverty level. About 65% are married or partnered. 90% identify as heterosexual, meaning that there's this large and growing database of LGBTQ+ caregivers that we can look at in the future. 18% are providing care to multiple care recipients, also a special group that we want to look at more closely. 13% live in a rural area, and 5% have Veterans Administration benefits. So looking at the care recipients, they tend to be related to the caregivers, tend to be related to the care recipients as children, about half, and a third are spouses caring for partners. Looking at the conditions, you see that 91% of the care recipients have memory loss, 46% can't be left alone, about 16% are prone to wandering, and 68% have a primary diagnosis of Alzheimer's disease or related dementia. So following Dr. Chi's presentation, I think this is important to think about. We look at Alzheimer's diagnosis, but there's a lot of people being cared for who don't yet have a formal diagnosis. So in this database, with 91% having some kind of memory loss, perhaps these are people who are going to be diagnosed in the future. In the next slide, thank you. You can see the caregiving intensity, and this is a measure that was developed by the AARP, and it looks at the number of hours of caregiving provided, plus the number of activities of daily living and instrumental activities of daily living that the person is supporting. And when you look down this bar, you see almost everybody is bright red. So more than 90% of the caregivers in the CRC system are doing care at a high level of intensity. We see this intensity increases with age. It's more intense among caregivers who identify as not being white or non-Hispanic, and it's more intense among caregivers who are living below the federal poverty level. In the next slide, you can see that along with this intensity comes very little paid and unpaid help. So the lightest part of these bars show people who are getting 0 to 10 hours of unpaid help on the left and 0 to 10 hours of unpaid help on the right. Of the caregivers that are being served here have no unpaid or paid help when they first sign up with CareNav or get their intake. These percentages are different by race and ethnicity. We see less paid help, unpaid help with older adults, maybe because their social networks are decreasing. We see less paid and unpaid help with lower income and less paid and unpaid help with rural versus urban residents. So starting to see some inequalities in how these things play out. In the next slide, we were able to do a comparison to two databases. One was a state database, a lot like the BRIFIS data that Dr. Chi presented. This is the California Health Interview Survey. And then we looked at national data, Caregiving in the US survey that's sponsored by AARP and the National Alliance for Caregivers. So you see here that the CCRC caregivers in California tend to be older. They tend to be more female. They're more diverse. They're less likely to be working, and they're more likely to be married or partnered. In the next slide, you see, thank you, that the number of hours of caregiving a week that they're engaged in is much, much higher. So here we're seeing 73% of these caregivers are doing more than 40 hours of caregiving a week, compared to 32% in the national data and 9% in the California Health Interview Survey. The relationship to the care recipient is different. So more of the CCRC caregivers are caring for a parent or a spouse partner. And more of them have a diagnosis, or they're caring for a recipient with ADRD. So 68% have Alzheimer's disease or related dementia. In the state and national surveys, that's only 5%. The care intensity is higher, so 90% for the CCRC caregivers compared to only 40% in the national data, and that was using exactly the same measure. And more of the CCRC caregivers are helping with medical and nursing tasks. So I think it's important to think about how these caregivers come to be in these databases. So this is, Dr. Chi talked about random selection. So when we randomly select caregivers, we're getting a nice sample of different situations, and we're probably getting people who have time to fill out long surveys. With the CCRC caregivers, we've got the people who are looking for help. They are calling up and saying, I need you now. And so it's a very different sample. It's the complete opposite of random, and it may be the population that needs help most. So in the next slide, you see that the outcomes of care are a little bit worse for CCRC caregivers. So more say that their health is fair or poor compared to excellent, very good, or good. More say that that caregiving has made their health worse, and more score as lonely on the UCLA loneliness scale. So just as a discussion points, we're seeing that most of these caregivers served by the California Caregiver Resource Centers are providing care for people who have memory loss or Alzheimer's or related dementias. They represent a help-seeking population that is engaged in very complex and high-intensity care in the home. We think that state and national surveys don't capture this intensity very well, and we think that the CareNav data is a very important adjunct when we're starting to think about developing interventions and policy for family caregivers who need support. Thank you very much.
Thank you so much, Dr. Bell. And it's really important for us to have data to drive decision making. So I'm so pleased that UC Davis School of Nursing, along with Family Caregiver Alliance, have done all this legwork. So we have a great discussion coming up. I understand that our next speaker may not have arrived in the Zoom room. So I'm going to basically switch to our next speaker. And it's Denise Lika. She is the Deputy Director of the Home and Community Living Division at the California Department of Aging. And she will talk to us on the subject, California's support for caregivers. So please take it away, Denise.
Hi, thank you, and good morning, everyone. So we've heard a lot about some of the research and the data that we see in the populations and in the community amongst our caregivers and what they're going through in terms of caring for our loved ones who are suffering from these challenges. But the next question is, what's available? What are the services out there for those that are in need of really having that support in the community? And so on this slide here, what you see is really the start of a continuum of care, if you will, of services, a range of services that vary in levels of intensity for many, and starting with information and assistance and education, and then all the way over to things like direct care, in-home support services, respite, and care management. So when you look at these boxes alone, you see a lot of things potentially being available for those that need the support and the help to remain living successfully in the community. But when we look a little deeper, there are some challenges behind this continuum. On the next slide, where we start to look at what are some of those barriers for access and barriers for these services reaching the individuals in need. First, not all of the boxes on the previous page are available statewide. And then if you look community to community, you see inconsistency in what's available as well. So it is very localized, if you will, in terms of what is even being offered there. Next, some barriers around eligibility criteria. Many of the programs, I'm sorry, previous slide, thank you. Many of the eligibility criteria may create barriers. They may be based on income needs. They may be based on diagnoses. They also may have limits in terms of geographic reach. So there is definitely another challenge. They could be fee-based as well. Some services you have to qualify for free services, others you might have to pay, and that may limit the ability for a family to be able to access. Capacity could be limited. We do know that the need is for many services in the state of California, the need is greater than the capacity that's available. And so that could be a challenge. Language barriers. The organization providing the services may not provide it in the preferred language spoken. Also, cultural appropriateness and navigation challenges to be able to really find these services and find those that fit and match the ethnic and diversity needs of our population. So with all of these challenges, there is hope though. So on the next slide, let's look at what we're doing to try to strengthen and broaden this work and the reach of these services. First, on the left, you see our statewide initiatives. Several of them listed there today have already been referenced, as well as we have some speakers that will come after me that will talk about these as well. So we have many projects that the state has been working collaboratively with the communities and with organizations across the state and with stakeholders like everybody on this call to really start bringing change and improving the system of care. On the right-hand side, we see master plan for aging initiatives that also fit with the existing work that's going on in order to build and grow our workforce and training, our community health workers programs, the service gaps, and identify the service gaps and be able to start to address them as we plan for the future and forward, as well as being able to bring in more awareness and new program models like Cal Compass that we'll be hearing next in our panel today. So all of this comes together that although we have an array of services that are available and models that have been tested and have been tried in communities and we have seen to be successful, we do need to continue to look forward on how we remove each of the barriers and the challenges so that we can have a true system that meets the needs, is ready and capable of being able to address the support system and be able to wrap around the caregivers and those living with dementia and other cognitive disorders, be able to really thrive in the community of their choice and remain safe. And so with that, we'll go ahead and turn it over to our next speaker.
Okay, thank you so much, Denise. And I'm so pleased to learn that both the state and the master plan of aging already have many initiatives working hand in hand and try to break the barrier. One thing I would like to point out is in breaking the barrier, we need to take into consideration seriously how to address the issues, for people who are non-English speaking or limited English speaking, and make sure that there's no language barrier. Otherwise, even though we have wonderful, work and a lineup for, future years, without that, accessibility, we won't be able to serve, everyone in a wonderful state like California. So thank you very much.
Great.
I'd like to move to our next speaker, and that is Celine Regalia, who is the Director of Operations at the Providence Community Health in Napa Valley. She's also a member of our committee, and she will cover the topic on California Community Program for Alzheimer's Services and Support. So over to you, Celine.
Good morning, everyone, and thank you for giving me the opportunity to speak about our Cal Compass project that we received grants for some sites throughout California, which will talk about the sites and the work that we've been doing over this past year. Next slide, please. So first of all, I just wanted to, ground us in the model of, for those of you who may not know, these are the descriptions from the California Association of Adult Day Services on the Adult Day Services model. As Denise was talking about, what's available in each community varies greatly, and what communities have in terms of adult day services also varies greatly. Some communities have social models, some have both, the health model and the social model. And then the Alzheimer Daycare Resource Centers was something that came out of the California department back in the 80s. And so we'll talk about how Cal Compass evolved and it is the evolution of the ADCRC model. So day programs, again, provide care for those living in the community that don't require 24 hours skilled nursing care. However, many times our participants meet the definition of somebody who is meets the definition of nursing facility level of care. And these programs help people stay mentally and physically active. As we saw in the pandemic, help people stay connected to community, be part of community in the day program, improve not only the health of the participant, but also, as previous speakers have mentioned, and we can see the impact of health on the caregiver. We focus on both the wellness of the participant attending our programs and also the wellness of the caregivers, and preventing the decline of their abilities over time. So we're considered one of the long-term services and support programs that is offered by the state. And then this is the Alzheimer Daycare Resource Center designation. Really, we're designed in the day as centers of excellence to care for people with moderate to late stages of Alzheimer's disease, and provide quality care, not only quality care, but provide training to our teams to provide high quality, non-pharmacological interventions and support for people living with a diagnosis, but also wrap that care plan around the participant. So the caregiver. So it's a 2-for-1 of the participant receiving a care plan and the caregiver receiving a care plan, and us following their progress over time. Next slide. So I just wanted to, this is an example. So if you've been to one adult day services program, you've been to one adult day services program. Same thing with Alzheimer Daycare Resource Centers. And most of us that deliver these services also deliver very person-centered care models to the needs in our community. So we became designated as an Alzheimer Daycare Resource Center in 1999. And when I first started, 25% of our population that came to their day program had some form of dementia. And today it is about 60% of the people who have Alzheimer's disease or related dementia that is admitted into our adult day services program. And we have both the adult day health model and we have the adult day program. So the Resource Center provides, accessibility to quality dementia care. We assist participants to function at the highest through therapeutic activities, and the therapeutic activities are based on brain health principles. If you're an adult day health center, then we provide physical therapy and occupational therapy. And if it's an adult day program, people are still getting, physical activity and therapeutic activities that are person-centered. We, throughout our process, as I mentioned, support the family caregivers by counseling, consultations, support groups. We have support groups in English and Spanish, education in English and Spanish. We provide respite. And then aligned with some of the initiatives that are moving forward, we also provide training opportunities for students. So interns, we do professional consultations and consultations, as I said, with our caregivers. And in our program, we've evolved as we started. When I first started as a social worker, we were, focused on the moderate to advanced. And then we saw that people were navigating out there with not much support. And so we started an early stage program. And so again, that's an example of how our communities can develop services based on the need. So prior to the pandemic, when we were coming in person, we offered about 300 family consultations a year. And this year we're doing about, 5 a week right now. And we're doing things more in person again with support groups and our early stage program. Consultations are led by a medical social worker. We come up with a care plan, and we also follow up to make sure that the information and referral that we've given to the caregiver are, support the needs that they currently have. As part of the consultation, they gain, what to expect on this journey, tips and tools to ensure safety, and we help deal with the behavioral and psychological symptoms of dementia. And then we refer and coordinate with other services in our community. Next slide. So CalCompass. So that gives you an idea of what an ADCRC, and the CalCompass that we are currently participating is based on the ADCR model, and it conforms with emerging science and national standards of dementia capable care. It really is this holistic approach that focuses on the person with the diagnosis and their care partners to do culturally informed work and to expand. The goal is to expand this program to day programs statewide. As we heard from Denise, not every community has the same resources, and so we want to build the capacity throughout our state to have the direct care services that our participants need. Next slide. And this slide just gives an example, and Denise showed those examples, so I won't read all these, but how we are really trying to align CalCompass with the current initiatives. So dimension focused, focusing around equity issues and not isolation, caregiving that works, also issues around the direct care workforce, aligning with the Alzheimer Task Force recommendations. And then we know that there's HCBS gap analysis that's currently going on, the NAP update, the RAISE plan that we heard in a previous committee meeting, and now the guide model that is being put out by CMS. Next slide. So the current CalCompass project sites, so there's Providence in Napa County, Opeka in Los Angeles, Hearts and Mind in Santa Clara, Peg Taylor in Butte County, and Tehama, that covers Tehama, Triple R in Sacramento, Alzheimer's Family Center of Orange County, and Choice in Aging in Contra Costa. And so currently, as CalCompass sites, we're serving over 1,000 individuals and caregivers through this project. And we hope, as I said, we hope to spread this work statewide by building the dementia capability of adult day programs throughout the state. Next slide. And so a partner in this project has been UC Davis, and these are some of the organization-specific outcomes. And so the funding helped all of us at centers to increase our own capacity about what we felt we needed in our community. So these are some of the examples: expanding capacity for language diversity, expanding enrollment, including better representation of our community diversity, increasing awareness, visibility, and outreach of our programs and awareness to make our communities more dementia capable and dementia aware, to improve the programming, increase our caregiver support programs. And then part of what we've been doing in this project is also looking at our assessments, tools, standardization, and screening methods that we will use in our CalCompass model. And then, as said previously, aligning with the master plan on aging objectives that you saw on the previous slide. Next slide. So this represents one of our participants, and he was diagnosed at age 48 with Alzheimer's disease, early onset, and his wife. He attended our day program, she attended our support groups, and eventually he passed on our hospice program. And so he got years of service through not only the day program, but his wife also got that support that she needed. They had young children. And so having him attend our program allowed her to keep her job, and our social worker provided ongoing emotional support through that. And then after he passed, he was able to receive bereavement services through our program. So prior to, I think, the Alzheimer Daycare Resource Centers were defunded in 2009. There was a statewide network of over 50 ADCRC sites, but many of us continued to serve as ADCRCs. And with our program, we did that through some family caregiver support program funding, and also through our foundation. And I want to also, I meant to mention it, but the middle income families are really the ones that also bear the brunt. They don't qualify for some of those programs that Denise was talking about in terms of eligibility. And so one of the ways that we address that affordability and access issue is by our foundation helping us support sliding fee scales so that people can afford that. They can't afford assisted living, they can't afford memory care. And so adult day services is one of those affordable options that's available in our communities. CalCompass has these 7 experience sites to rebuild this comprehensive resource. We know that there are more than 690,000 individuals in California that are being identified, and that this population is growing. And with all the great things like dementia care aware and all that infrastructure that Denise showed, we're going to be, screening and adding substantially to the numbers of people, and people need direct care. People need a place to go to. And so we hope that CalCompass will be that solution for creating a network of support for family caregivers and people living with a diagnosis. There's no other community-based resources that have the expertise and effectiveness of the Alzheimer Daycare Resource Centers for preventing isolation, increasing engagement, and maintaining improved function over time. And as I mentioned earlier, we are one of the few non-pharmacological treatments for people living with the diagnosis, and can extend and maintain their physical, emotional, and cognitive function. Next slide. Kind of have covered this, but this is the idea, is that the licensed adult day service programs will serve as these therapeutic hubs, and that we will build the capacity throughout the state. Next slide. And this is my final slide. So this is where we are right now with the CalCompass and our next steps. So we want to bring these, we want to create these dementia capable services throughout the state, bridge funding to support the next phase of our work. And then also identify individuals living with dementia, special population with distinct needs. And we think that there's some opportunities both within CalAIM to name Alzheimer's as a special population, and also build in that expertise with the ADRCs. We want to mentor sites to create a statewide network. Currently, there's over, I think, 270 adult day healthcare programs in California and 300 adult day programs. Our programs and services are also seeing an increased need of serving the people with intellectual disabilities. And I know that our program has seen a big rise in caring for that population in our Alzheimer Daycare Resource Centers. And then at the state level, CADS, the California Association of Adult Day Services, is looking at rate reform for the sustainability of our adult day services model. And with that, I thank you very much for your time.
Thank you so much, Celine, for presenting this great, initiative. On a personal note, I want to mention that my mother, before she passed away, attended the Alzheimer's Daycare Resource Center based in San Francisco, Self for the Elderly, and my sister, who was the primary caregiver, really received a much needed, respite, having our mom, attended that program, and also got support from the staff who provided us with, tips on how to handle individuals with dementia. and my mom had vascular dementia, eventually had Alzheimer's. But the 690,000, in 2020 basically reminded many of us, and our mom was one of those individuals being counted towards the 690K. That this is continuing to grow, as Celine mentioned. The early onset of that participant that she served really remind us that this is a brand new game, and we need to be more aware of Alzheimer's and related disorders. And so having a committee such as this is really important, because we'll bring best practices, bring issues to the attention of the state government, so that the great state of California can continue to work on the policy and provide wonderful services. So talking about personal experience, I would like to invite the next speaker. Her name is Hilda Gutierrez. She is a caregiver, and she's going to talk about her experience. So over to you, Hilda. And we have a short video to play before Hilda is going to speak. So can we start the reel, please?
I open it. I try to open my camera, but it's not come through. I don't know why. Oh my gosh. Oh, well, I am here anyway. Let me see, start video.
Welcome.
Okay. Let me see.
So we show the video after you finish speaking.
Oh. Are you hear me?
Yes. Go ahead, please.
Okay. I don't see my face on the top, but my mother, Teresa, you want to see something about this picture, so I can say my experience like a caregiver?
Please talk about your experience as a caregiver, and then we can play the video.
Okay. Okay.
You.
Okay. Good morning, everybody. My name is Hilda Gutierrez, and I am caregiver of my mother, Teresa. My mother is 87 years old. She has diabetic, heart problems, dementia, and depression, and anxiety. She takes many medicines, but she is available to walk with a walker. I feel like to be available to care her, but it is very hard because she doesn't sleep well, waking up every 1 or 2 hours, asking for medicines all the time. She is very sad and cries and breaks my heart. She eats only a few things. It is very hard to give in her healthy food. She likes too many sweets. She likes to go to the adult day program. I'm sorry. The program, it is very helpful to my family and blessed. She loved to go to the program and share her stories, jokes, and talents with her friends. Mondays, it is the best day because she's sewing and be part of the group. The personnel of Providence are very professional and capacity work with the adult people, have a nurse, staff, and all they need. I was participate on trainings with dementia and Alzheimer many times, who was helping me a lot to understand the condition. My suggestions are maybe have services for nights and services for crisis to call somebody when we have questions after hours people work, and giving more hours for IHSS. And probably I can talk more, but I have only a few minutes. But thank you very much for your support us and for the other families too who need these services. God bless you. Thank you.
Thank you so much, Hilda. And I understand we have a short video, right? So we can play it now. we'll bring it up as soon as we can. So, all right, here we go.
Ahora se llama providencia, que nos da alimento, vida y sustento. Amén.
She was, I was sending another one. I don't know if you were receiving, because she was talking about how she loved the program, how loved all the people, and she was appreciate every day what is the people are working with her.
Yeah, that would be great. Thank you for sharing that. And actually, that reminded me of my mom, and she talked about how glad she was, when she attended the program, and really makes a big difference in, enhancing the quality of life of
Yes.
People afflicted with Alzheimer's and related dementia. So thank you, Hilda.
You're welcome.
And I guess maybe we can move forward to the next speaker first before we come back to the video, if we can bring it up again. So the next speaker actually is my dear friend and colleague whom I've worked with for many, many years. That's Kathy Kelly. She's the executive director of the Family Caregiver Alliance. And she's going to discuss with us the Caregiver Resource Centers. So over to you, Kathy.
Thank you, Derek. We truly have been in the trenches together for a very long time on these issues. Next slide. I'm going to talk a little bit about the Caregiver Resource Center system in the state of California, and the increased usage of technology in terms of service delivery across the state within the system. California, really has led the country very early on. We did pass the first legislation that recognized family caregivers and of persons that have cognitive impairment, mostly dementia. And that was established in a pilot project, but in a replication in 1984. So California has a long tradition in working in this area long before it was really, became a well-known and a well-researched area as it is now. To understand the CRC is to understand that we looked at the models in terms of the replication issues, and really looked at the regional center system statewide. It's a network of community-based nonprofits. They, do assessments and coordination of internal and external types of services, contracts for services, for their clients. And the real important point is that you link to the resources. You have internal and external abilities, of course, but you also follow clients over a long period of time. And in the case of the regional centers, it's basically, it's almost the cradle to grave long-term care system. And you look at the changing needs over time. And of course, we know that there are definitely changing needs in certain developmental disabilities populations as they age. And it's located under one department, but operates uniquely within the communities that they serve. This follows a model for us because we do follow people longitudinally over time. And over half of our clients that we work with during the course of a year are actually returning clients from prior years. And that could be anywhere from last year's client, that we touched to somebody that we've seen over the course of 10 years or more. So that's not unusual for us. Next slide. Next slide, please. Thank you. So we have a defined package of services that are administered by all the Caregiver Resource Centers statewide. We target persons with adult onset cognitive impairment, excluding developmental disabilities and behavioral health. That was a component of the legislation early on. But we have many, many different types of cognitive impairments. The largest being with you saw with Janice's readout of the data from this year were some form of dementia. But we also deal with a lot of other disabilities that may have more sudden onset, like stroke or late in life head injuries or noxic brain damage. There's a lot of different kinds of diagnosis that we deal with, but all have the commonality of loss of cognitive functioning and family members and others needing to step in for support. We serve all income groups. About 25% roughly are those that are eligible for Medi-Cal services, but we really were created in part to serve everybody throughout the state, but we largely serve the missing middle income individuals, and particularly lower middle income individuals that are really at a distinct disadvantage because there's few services out there that are really accessible on a private pay basis or even a sliding fee scale basis. We use and always have used a uniform intake and assessment. We cover the multiple domains that Janice alluded to. We have actually fairly in-depth information covering, a long period of time of tracking these clients over many, many years, which makes it a fairly unique kind of database to be developing out in this iteration. We also have standardized education and training for onboarding staff, and there's continual training across the state on key issues that have been identified as really essential to either changes in practice and definitely for quality assurance of the integrity of information and experience that the caregivers, receive from the CRC. The data that is collected, it can be used for site-specific knowledge. In other words, because it's collected within a record system, all sites will have the ability to run their own data in terms of who they're serving, where their clients are located, diversity, of their population, many, many different things. They essentially can run their own data and see what's going on, which is a little bit different in terms of giving people the access to that information on a program level basis, so they can really look at their unique characteristics of the community in which they serve. It also drives this measure impact and changes in population. We identify problems. It's for basically driving quality improvements across the system. There is an annual report. There always has been, except for the years between fiscal year 2008 and fiscal year 2019, when there was a significant decrease in the contract amounts by 75%. So many of these data collection pieces went dormant during that period, unfortunately. But we've picked that back up with the new record system, the data collection system that we have within CareNav. But there has always been an annual report. So all of the, anybody, it's a public document, anyone can see the annual report, but most importantly, it does go back to the staff to see how the practice has changed, and new issues that have come up are always addressed within these, this particular project description that's done by the UCD evaluation team for the staff every single year. Next slide. Okay, the package of services, the intake and assessment, care plan consultation, many of these things are things that these are standardized practices, whether it's here or within the adult day care system. Legal financial information and consultation. We do have respite vouchers We use a direct consumer-directed choice and options model, which is caregivers can choose, the family can choose the values and preferences for receiving respite options. Many different CBT, psychoeducational interventions are conducted throughout the CRC system. We do our support groups as professionally led groups. Of course, there's always linkages to other community resources. Next slide, please. We have specialized training for direct care issues that comes up quite a bit because particularly in this sample, we have a much more serious and complex care need. So direct care is actually vastly increased with this particular stage. Many education programs are offered throughout the state. I'll just give you a sort of a little preview. We had about over 700 different classes. Some were available to caregivers throughout the state. Some were available only in those regions. We served about 28,000 people through these education programs. So it's a pretty robust system. The calendars and training classes for anywhere, anytime is now exceeding 50,000. So we're reaching people with consistent information. We also have a database of consumer content. I'll talk about this a little bit later in terms of where it writes. It's in the CareNav system. It's over 400 different pieces of content across a variety of platforms. And many of these pieces of content with fact sheets and even our audio and video are translated. This is a moving target. This is sort of a pool of to give you an idea of some of the languages. 72 pieces are in Spanish and 60 are in Chinese, 40 in Vietnamese. We have Tagalog, we have Korean, but we start from the most used and most often requested and the broadest level of content. First, we start to translate our fact sheets with the ones that are going to get obviously the most used. So this content does ride in the CareNav database. It's available to the staff. It's also available to clients through the CareNav model or through request. Next slide, please. So in 2019, the CRCs advocated for a budget augmentation that to increase the service delivery and the cross-CRC collaboration, but more importantly, to utilize the new technologies that were available and emerging across the state and the ease and use of technology for many of our daily functions sort of pointed us in the direction that this was a time to be able to punt this interactive client record system up, since more people are using technology than ever to do just almost every function in their daily transactions. So we wanted to be able to use these technologies to extend services, and we found that to be quite true. Obviously, we were a little ahead of the curve. It didn't ever dawn on us that we'd have a pandemic, that extending services this way might be the only way to provide services during the COVID period. We also wanted to standardize the quality practice and core services and collect data for the evaluation reports. So we went for a budget augmentation. Next slide, please. And we received $30 million over a 3-year arc, $10 million a year. It brings us up to a $15 million a year total appropriation. This was later memorialized. This was a 3-year project, but memorialized in, I think, 2021. So we were able to install CareNav throughout the system. There were 3 CRCs at that point that were starting to use CareNav. There's a client-facing portal to this. Individuals can come in and start their own record, and also consult their dashboard when they so choose. So we did the CareNav install. We also installed and taught telehealth consults, so individuals could, CRCs could be using the Zoom Health platform, which is HIPAA compliant. So all of these things are HIPAA compliant technologies for consults, encounters, small group trainings, support groups, and so on. So we trained staff on CareNav, all these communication technologies, and started the statewide evaluation and outreach. The first year was on the process implementation, which is, actually a very good evaluation of what it takes to really start to embed technologies, but most importantly, bring about system change. Next slide, please. So Janice talked a little bit about this. CareNav is a cloud-based HIPAA compliant client record system. In full disclosure, we did develop this at Family Caregiver Alliance over a multi-year period using private foundation dollars. Families can start and open their own record. There's a client dashboard with functionalities. There's also a fairly sophisticated backend for data entry, for service data and reports for payment sources. I would add that the CRC contracts are not the only sources of funding for the services. We also have Title III and county funds and other foundation grants, and we're able to track these multiple payer sources and blend the funding sources. So it's not apparent to the end user, the family caregiver, why should they worry about that? But we certainly can do the reporting for all of the different requirements across these payer sources too. I talked about the real-time data for site uses. That's there. We also use it in a variety of other use cases, including two national research projects that are going on that use CareNav as the hub for service delivery and tracking information around engagement in the materials. Next slide, please. Every CRC on their website has a portal that you go through. This is just ours. You can go immediately to CareNav. Next slide, please. You looked at this is a registration. We have a two-step authentication process. I think you saw this in Janice's presentation. Next slide, please. This is an intake, the start of an intake. You can see that we're asking about, basically about caregiver, basic demographics, who they are providing assistance to, what are the current needs, and then it goes to the dashboard. This is the first stage. Next slide, please. This is the opening shot. I don't think this is very compelling, but this is obviously a test case. Sarah Lopez, she didn't finish the intake. It says that's what your next step is, but it gives you an idea. The library messages support group classes will have a My Records section in the next phase. Next slide, please. As people are answering questions, whether it's on intake or assessment, we've scored the content to come up so the information is tailored to responses. In this case, you'll see that there are just a whole line of resources, information that's available, where it's coming from, whether it was recommended by CareNav or by the care consultant, or whether it was their preference. All of this information is available. They also can browse the entire library under direct care, planning for care, self-care, and health conditions. There are other functions that you can see. We always give a reality check about the contact information about the CRC, who their family consultant is. They can send a private message, a HIPAA compliant message, and other links that we supply that provide some information about navigation through the site. Next slide, please. One of the things that we have made an improvement on is being able to put the statewide classes, information, workshops in there. They can go through and check the classes. We have probably, I'm trying to think, there's usually somewhere between 20 and 30 classes a month that come up for individuals. They can directly register from the site. So it gives them a secondary pathway. Most of these classes also go out through monthly newsletters, but we've embedded them now in CareNav. So they're always there available for people to review. Next slide. So what are the next steps? This is just generalized, increase reach into diverse communities. We know who we've reached. We're embarking on looking at diversity and social determinants of health, and mapping areas that are probably would choose to be, really good targets within communities based on a number of different metrics. Quality assurance is always an issue to make sure that the staff has the most up-to-date information. We have consistent practice standards. We're improving the practice across the state for staff. There's about 140 staff members, including admin staff within the CRC system. But assuring quality is always a number one priority. Particularly in data collection, make sure that we have data integrity. And then how do we use the data? We have a lot of information at our disposal, but how do we best use that data to identify and target the high need service areas? So with that, I think that's the last slide. Thank you.
Thank you so much, Kathy. I'm especially impressed by your language capacity, having information, not just for Spanish or Chinese speaking individuals, but also Vietnamese and Tagalog, and very impressive. Thank you so much.
You're welcome.
Our next speaker, by the way, is one of our own member of our committee and also a dear friend and colleague of mine. That is Dr. Dolores Gallagher-Thompson, who is a professor emerita of the Stanford University. And she's going to talk about caregiver behavioral health. So over to you, Dolores.
Thank you very much, Derek. So I'm really glad to be here and to have the opportunity to share with you what I've learned over the years about improving caregiver behavioral health. So may I have the next slide, please? I'd like to call your attention to 5 books that expand on the information that I will be sharing with you today. The first I'm very pleased about. It's a recent publication by several colleagues and myself called Family Caregiver Distress. And this book is kind of a primer for those who would like to learn more about mental health issues and how to assess, how to treat, what are some of the evidence-based programs that are out there. And so it's recommended for people who would like to get that background all in one place. The middle 2 are updates of our books on treating later life depression, which contain specific chapters on working with caregivers from a CBT perspective. There's a clinician guide and a workbook for clients. Then to the far right, we have psychological assessment and treatment of older adults. Again, there are chapters specific to caregiving. And lastly, ethnicity and the dementia. This is the 3rd edition, which has chapters on a variety of diverse groups. The chapters go into the patient, how the patients present in different ways based upon their cultural backgrounds, and then what can be done with the patient and with the caregiver. What are some effective ways to intervene? So next slide, please. So for further, more in-depth information, please consult those sources. I love this slide. Both of them feel confused, frustrated, and helpless. Only one of them has Alzheimer's. Next slide, please. We all know that caregivers are the hidden patient. We've heard from several sources earlier that they are depressed, Many studies put the depression rate at as close to 50%, significantly depressed on instruments like the PHQ-9. Many suffer from high stress, feelings of being overwhelmed, anxiety about the future, other negative feelings we don't think about as much, like guilt and frustration and feelings of inadequacy. Social isolation, we've heard about that increases over time. And of course, the financial strain on the caregiver. Many have to leave their jobs or reduce their number of work hours. So the next slide. We hear from the report of the National Alliance for Caregiving and AARP in May of 2020. They use a slightly different way of describing this. They talk about 4 in 10 experiencing high emotional strain, most of which are women, and that this level of strain or reported strain varies by race and ethnicity. Roughly 40% of Asian Americans that they surveyed compared to about 30% of African American and Latino individuals. Next slide. So clearly, mental health issues are a problem or are salient for whatever group we're talking about. We've seen these, we've heard about these negative effects, but I'd like to call your attention to cognitive problems of the caregiver. These are more common in older caregivers who may themselves be experiencing some memory difficulties. We often do not assess the caregiver for cognitive function, and I would suggest that it is important to do that when the caregiver themselves are over 65 or 70. We also know that caregiving can have negative health effects. 2 in particular have been delineated in the literature. One is compromised immune system. Caregivers take longer to heal from colds and flu and things of that nature because their immune systems are run down, typically. And the other one that's been documented is dysregulation of the HPA axis, which involves the hormone cortisol. And that's important because dysregulated cortisol over a long time, like we've seen the length of time that many are caregivers, if they have that pattern, this can lead downstream to serious medical issues, heart disease, diabetes, and the things like that. So we want to preserve the caregiver's mental health and physical health as long as we can. The next slide. We overlook often the positive aspects of caregiving that are really important in preserving mental health. We don't want to just focus on the negative. We want to look at whether or not the caregiver has been able to experience some personal growth, whether caregiving has given their life some meaning and purpose. Perhaps their cognitive skills have sharpened because they have so many things to remember, not only about themselves and their own appointments and medicines and so forth, but they have to remember their loved ones as well. So for some caregivers, this improves their memory functioning. And some, if they have the routine of physical activity with their care recipient, can have health benefits. So it depends on how they participate in physical activity. And finally, caregivers who can report both positive and negative aspects of caregiving tend to have better mood than caregivers who focus on the negative. That may seem obvious, but it's important for intervention development because many of our interventions have worked on reducing the negative rather than increasing the positive or trying to balance the two. So the next slide, let's skip that one. I think we all know now what causes caregiving to be stressful. I don't think we need to talk anymore about that. This one, though, I would like to call your attention to. Maria Aranda, who I'm sure many of you know, recently published a very interesting paper on how to involve Latinos more in Alzheimer's disease clinical trials. What some of the issues were with clinical trial enrollment, because we know that we need more research on the patients themselves. We also need concomitant research on the caregivers. But she points out in the paper that often providers are not equipped with culturally relevant or linguistically appropriate methods that allow them to understand the unique needs of caregivers of diverse racial and ethnic backgrounds. So we've made some progress. Clearly, you've heard from other speakers that there are programs, there are services, there are educational materials available in multiple languages and so forth, but providers aren't necessarily equipped. In other words, they may not have the training or the background necessary to be able to implement mental health intervention programs in a culturally sensitive way. Next slide, please. Here we see a conceptual model that was published over a decade ago by Bob Knight and Phil Saye at USC. The model is still very relevant today, not only for diverse caregivers, but particularly for diverse caregivers, where the importance of learning about cultural values, beliefs, and practices is emphasized. So cultural values, what do we mean by that? Well, for example, in the Latino culture, familismo is a cultural value that's cherished. And it can have a positive effect on the caregiver's mental health or a negative effect, depending upon how it is carried out. So, for example, it would mean that the family would engage in caregiving tasks and responsibilities. They would see caregiving as kind of a family affair and act accordingly. But not all Latino families do that. So the greater the level of acculturation of the members, particularly the younger caregivers, the less they are likely to help with caregiving tasks and responsibilities, the less they are likely to be involved. So if we understand the cultural value and we understand how it is being displayed in that particular family, it can help us with our interventions. Similarly, the kinds of support available. So many of the South Asian Indian clients that I've worked with, one of their chief sources of support is in India. So it's a continent away. It is not here. And that's a different kind of support than support that's readily available on a day-to-day basis, that's co-located with where you are. So learning about these things is important in how you choose an intervention, and then how you actually administer or utilize that intervention. Next slide, please. Is a little more on the sociocultural context, and I'll just give another example here of how it can influence caregiver distress. So in many Asian cultures, the value of filial piety is quite strong. And what this generally means is that the family comes first. And so the needs of the caregiver may be secondary. And for caregivers who are very stressed, this may lead to their needs being ignored until they are quite serious and the mental health issues really need to be addressed. So language barriers, we've heard about that. Culturally insensitive services, unfortunately, are part of what we need to be aware of when we're thinking about interventions. The provider brings their own sociocultural history. And is that going to promote a good relationship or get in the way? Important question for us to ask ourselves. Next slide, please. Here we give you a tremendous resource, a snapshot of the website for the resource that's been created by Family Caregiver Alliance and Benjamin Rose Institute working together. It's the best practice caregiving registry. So for those of you not familiar with it, it gives it gives a lot of information about evidence-based programs. And for example, not only the name of the program, but the length of the program, the kind of training that's needed to administer the program, the languages that the program is in, and then how it's done. Is it done in a small group? Is it done face-to-face or online? So you get a lot of information. These programs have been carefully vetted by the team at Benjamin Rose Institute. So you can feel confident if you choose programs from this registry that you're up to date. They update the registry very regularly, and all the programs are removed that are no longer in existence for one reason or another, and new programs are added. So it's a great resource, and I hope you'll utilize it. Next slide presents the stepped approach that we've developed for thinking about and selecting interventions. There are 4 levels of care in this stepped approach. The first 2 we've heard a lot about, and I think we'd all agree that they are very essential to good mental health of the caregiver, which is, first of all, education about dementia, and then education about self-care approaches. That's level 1. Level 2 would be use of the community resources. So referral to community resources, perhaps having a care manager, a social worker to help sort things out, what's needed to reduce the stress in the family and on the caregiver, and involving the family more if possible. Now, levels 3 and 4 are those that are geared more specifically to mental health. So level 3 would be the psychoeducational programs, of which there are a good number now, some of which are already being offered in California. Probably most of you are familiar with the Savvy Caregiving Program, but there are others that I'll talk about. And then level 4 would be specialized care, where a person might need medication for depression or anxiety. They might benefit from psychotherapy, short-term therapy focused on caregiver issues. So those are level 3 and 4 is what I'll focus on in the time remaining. Next slide, please. I want to show you this diagram that we created on the trajectory of caregiving. It's obviously too complicated to explain in depth, but you can refer to it in your handout. The idea here is that the different interventions are going to be better for caregivers at different points in the trajectory. So what a caregiver needs in terms of mental health care when they're in the early stage, their loved one is in the early stage of dementia, is not the same as what they're going to need when the loved one is in the later stages of dementia. And we've tried to flesh it out here in this diagram, which is published in an issue in the Gerontologist a few years back. We also wanted to point out the culture again, the cultural context. So here, though, we're talking about not only the heritage culture, but the healthcare systems culture. Every system that we've heard about today has its own culture, its own way of operating, its own pluses and minuses, its own do's and don'ts. And so for a caregiver to effectively use healthcare systems and community-based organizations, they need to learn how. That's an important aspect of mental health as well. Why? Because we become very frustrated when we're caregivers and we're trying to access services and we don't know what the services are, or we might not know how best to access them. So these intersect to help us decide what to do, what to offer the caregiver. That's going to improve their mental health. Next slide. We strongly recommend that any agency or provider who gives direct services to caregivers should do at least 3 assessments. These are quick, they are online, they are downloadable, they are free, and they are in multiple languages. The first is the PHQ-2, which is a screen for depression. If the person screens positive, then the whole PHQ-9 is administered. And there are established cutoff scores and very good information about what interventions might go with what level of depression based on the PHQ-9. The GAD-2 screens for anxiety. GAD, it stands for generalized anxiety disorder. The 7 is the follow-up. It gets at more aspects like worry and so forth. And again, there are established cutoffs. The caregiver self-assessment questionnaire focuses on stress related to caregiving itself. Next slide, please. If you want further information about assessment tools, please check out our book, because we go into great detail about other kinds of assessment tools and where to get them. I said I would focus on levels 3 and 4. So level 3, the psychoeducational programs, they are extremely useful because they were developed because caregivers don't usually think of themselves as clients. They don't recognize their mental health needs often. If they do, they often don't seek help because their focus is on the care recipient. Psychoeducational programs take away the stigma. The caregiver does not have to identify as a client or a patient. They are coming to get information. These are typically done in a workshop format, but the theoretical basis is cognitive behavior therapy and development of self-efficacy skills. That's where all of these programs came from originally. Usually they're small in number, they're a closed cohort. They might meet weekly or on some given schedule for a specific period of time. And they can be done in person. Many were developed in person originally and now have migrated to the HIPAA compliant Zoom platform. So I'm going to talk a little bit about two of them that I'm personally very involved with, the Coping with Caregiving that I helped to develop, and the Caregiver Thrive, Learn, and Connect. So Coping with Caregiving has been culturally adapted and is available in Mandarin Chinese, in Vietnamese, and in Spanish. The Caregiver Thrive, Learn, and Connect is in English right now, but it's being culturally adapted for Spanish in collaboration with the Southern Caregiver Resource Center in San Diego. Next slide, please. So what are the core elements of the Coping with Caregiving program? There are 4 skills that we teach in Coping with Caregiving. And again, this is comparable across the other programs as well. Behavioral activation, cognitive reframing, identifying problem behaviors, what came before and what the response is, and then improving communication. We believe that change occurs because of increased self-efficacy and emphasis on practicing skills so that the caregivers learn new healthy habits. The next slide, please. The core elements of the Caregiver TLC program. In this program, we added the positive aspects of caregiving that I mentioned before. We focus in this program on building resilience. So the 2 topics that were added are called bouncing back and filling the well. And this program has gone over extremely well for that particular population of caregivers who, as I say previously, we focused a lot on reducing the negatives, but this program builds up the positives. Let's skip the next slide and let me go quickly into intervention. So Derek, you said I have about 2 more minutes. Is that right?
Yes, please.
A couple of minutes. Okay. So level 4 psychotherapy, this is when the PHQ-9 would indicate that the person is highly distressed, highly depressed. The 2 most commonly used with the evidence base are cognitive behavior therapy and acceptance and commitment therapy. So next slide. Cognitive behavior therapy, for those of you not familiar with it, it's present-oriented, problem-focused, and encourages flexibility. It also uses a skill-building approach, and we develop maintenance plans to help the client prepare for the future. Next slide. Using it with family caregivers, I'll go as fast as I can here. Using it with family caregivers, we identify what aspects of caregiving are most related to the depression. And typically it's unhelpful negative thinking patterns that caregivers have about themselves, plus unhealthy behavioral patterns. So CBT with family caregivers focuses on unhelpful thinking and changing or modifying unhelpful behavior of the caregiver so that they can do a better job and remain caregivers longer. So if you'd like me to stop there, I'll be happy to. If there's time, I could continue. I have a few more slides.
Actually, give you 1 more minute. So Barbara actually can talk about gaps and future directions.
Okay, did you say 1 more minute?
Yes, 1 more. Thank you.
Okay. All right, so let's skip a few slides and go to acceptance and commitment therapy. So in this therapy, keep going. Yep, there we go. Its starting point is different. It's accepting the problems that are there rather than trying to change them. Acceptance is a mental process. It often involves mindfulness exercises and cognitive reframing, that there are many things in dementia caregiving that you cannot change and that you cannot control. So learning to accept and be comfortable with that is the first step, according to this form of therapy. It's the first step to improved mental health. From there, you can develop active coping strategies. and you can use them very successfully. The next few slides talk about augmentation of therapies with online support groups, helplines, and technology. And then finally, I'll end with the main gaps, what I think are the main gaps before Barbara speaks. And the first one, I think the first main gap is to recognize that mental health matters and that there are interventions, there are programs for effective programs to help reduce the mental health problems of caregivers, particularly depression and chronic stress, anxiety as well. Those are the three for which the programs have mainly been effective. There are some culturally and linguistically appropriate interventions, but we need more research so that we can find the flex point in that trajectory of caregiving when we would use one intervention over another and feel confident that we're making the right decision. So thank you very much for giving me the time.
Thank you so much, Dolores. I'm glad to see that you point out the importance of having culturally relevant and linguistically appropriate interventions. Well, next, actually, I'm so pleased to ask Barbara McClendon, who is also a member of a committee, and she's the policy director at the Alzheimer's Los Angeles, to talk about gaps and future directions. So over to you, Barbara.
Thank you, Derek. So I know we're running a bit behind. How much time do you want me to take care? I think we were supposed to be done.
Yeah, in terms of time check, we need to have a segment for Q&A, but also Dr. Galy will be joining us at 11:55 for only 5 minutes. So.
Okay, so so much information this morning, and I don't even know if we need there's nothing else in that slide. If you want to take the slide down, it'd be great to see committee members, if we can do that. If not, that's fine. You can look at me and the ASL interpreter. So a couple of ideas just come right to mind listening to both the data that was presented at first and then all of the information about the variety of services. So there's a lot out there, I think, is the first thing that comes to mind, right? But how do people find it and connect to it? And so I don't know if Susan DeMorris later might be talking to us about the No Wrong Door initiative and where that stands. I think that's going to be essential, because we need people to be able to enter the system of connecting to services. And so if that No Wrong Door system can be done comprehensively and thoughtfully, which I know that's what state staff are working on so hard right now, with an eye towards dementia and cognitive impairment specifically, so that we can make sure that people can actually get to some of these services that have been identified here today. Though obviously we have to acknowledge that there are, again, I think the number earlier this in our meeting today was 1.1 million caregivers caring for someone who's living with a dementia. That's a lot of caregivers, so they're going to need a lot of services. So obviously, to some degree, there's no getting away from. We just need more money to flow into this area of service delivery. Something else that really stuck out at me when we were looking at that data was how many people who are caring for someone are in that sandwich generation. So it really strikes me that I think there's a role here for our employers. And I don't know if maybe there's a matching role for the state, or if this committee could make a recommendation. Can we package for employers services for caregivers, specifically for people with Alzheimer's and dementia? And so we can make it easy for employers to connect with their employees. I think we also heard today that there needs to be work done for people to recognize that they're a caregiver, to self-identify in that way, to even begin looking for services. So I think there's a role there for employers to play as well. And so that might be another avenue that we can bring people into this system, hopefully this fabulous No Wrong Door system that we'll have, so that we can then connect people to some of these services. And then I can just wrap with speaking directly to where we were left with that fantastic presentation about mental health. And I know this committee over time has looked at this issue. When we're talking about mental health and Alzheimer's and dementia, often we've got a double layer of stigma. So a lot of people across a variety of cultures have some reluctance to acknowledge and access services for mental health, combined with a feeling of stigma around the dementia that may be driving that need to access those supportive services. So a deeper dive into what the Older Adult Behavioral Health Initiative includes may also highlight for us both what some of these gaps are and maybe what some future steps are that we can take. I also will just say for the Mental Health Services, the Oversight and Advisory Committee, just watching their work over time, and I understand this, but I have to admit to some frustration with it, and that is just a really strong focus on youth and families, which again, I really get. But you know, if our committee could maybe do some outreach to that entity to say, hey, let's not forget about the older adults and the significant mental health needs that community has as well. And I'll stop there.
Thank you, Barbara, for covering this very important subject. Now I think Barbara is continuing to facilitate the committee question and answer. So over to you again.
Yeah. So I guess we're opening now to thoughts that committee members have about the information that you heard this morning, questions. We've got fabulous state agency staff who are with us today, so can answer some of those questions. And I can't see everybody because we've got some of us spotlighted, so I think you may need to raise your hand or just speak up if you'd like to make a comment or ask a question. Oh, fabulous. Now I can see everybody. That's great. Thoughts, concerns, other areas that you feel we didn't get to, gaps that haven't been identified, thoughts you have about the role this committee can play in helping to address some of those. All of that is welcome. We're all just stunned into silence by the amount of information that we've been given. I mean, maybe, Derek, because I do think some of what Susan is going to be speaking to later this afternoon is just really going to be so relevant to this discussion. So it might be that we could kind of pick this back up as part of that.
Absolutely.
Her presentation.
Yeah, absolutely. And so I think the committee can wait until that moment. In the meantime, from the public, we do have one question, and that is, does our committee see a way to support the continuity of the Cal Compass model? So anyone who would like to address that? So that question is from Debbie Toth, another friend of mine who is with Choice in Aging. So thank you very much, Debbie.
So I could just jump in here, and Michelle, you can maybe corroborate this or not. But this committee has definitely made recommendations about bills that we think should be supported, budget asks that we think should be supported. So I think that that's within the purview of the committee to make a statement that we see the value of this program and, you know, encourage continued support for it. I don't know if there's, Michelle, if there's limitations at all on what we can, how active our advocacy can be, how direct our advocacy can be. You're muted if you're.
Now can you hear me?
Yeah, I can hear you. Yes.
I don't know as a committee as how much you've specifically taken positions on bills, but I do know that so after every meeting, we send a letter to Secretary Galy with your recommendations. So at the end of the meeting today, when Derek's kind of collecting those, if there's something that people want to put forward around these types, you know, the specific program or services, we could definitely make sure that that gets noted in the letter that goes to Secretary Galy.
Because one of the things that really stuck out to me in Celine's presentation was that the services they're offering cover the whole the journey that families are on, right? From the very beginning all the way through those bereavement services. I mean, I just think that's so important when you're talking about Alzheimer's and dementia, which, as we all know, is a progressive disease. So those caregiver needs are just shifting all along that progression, along with the person living with the disease. And so that, you know, if we can be encouraging a service delivery system that moves with them, which, you know, the Alzheimer's Daycare Resource Centers does, I mean, that just seems to make a lot of sense to me.
I'd like to take a pause right now because we have a special guest whom we just talked about, you know, how can we really recommend, you know, any issues or concerns to this individual, and that's Dr. Galy. And so Secretary Galy, please go ahead and, you know, this is your airtime.
Sure. Well, thank you. And Barbara, sorry to interrupt your train of thought and thinking. Probably more exciting for me to hear what you're talking about in the conversation today than to hear a few words from me, but I'm going to try to do my best and happy to take a couple of questions. And hopefully, Derek, I don't interrupt the flow of conversation too much. First, let me start with the apology that I wasn't available earlier in the day. Thank you, Darcy, for stepping in, and Susan for coordinating that. It's probably not unlike some of the caregiver situations that I know you guys hear about or participate in. You get thrown a sort of unexpected curveball, and then you have to address it for a little bit. Let me just first thank you all for your ongoing service on the advisory committee. I know this is an important month both for Alzheimer's awareness and family caregivers, and I know that's part of the conversation you're having today. I've been spending quite a bit of my time talking about caregiving and the quote care economy on both ends. What does this mean for young people and supporting kids and children? And what does it mean for those living with disabilities and those older Californians, and making sure that we get their support? And throughout all of it, I'm thinking about what I often call the biggest privilege of my life, which was providing care to my own father at the end of his life. I was a resident at UCSF in San Francisco. My parents had moved from the Midwest to live near their kids down in San Mateo. So I did the 45-minute commute down there, probably 4 or 5 days a week, helping my dad live with chronic renal disease and on dialysis. We were the first family in California to do home hemodialysis, and it helped to have 2 physician sons who could help support that. But it was exhausting and always full of ups and downs and emotional. But as I said, and I think arguably in the role that I've had over the past 5 years, I've had some pretty incredible opportunities to serve. Yet that moment with my dad and taking care of him at the end of his life is by far the most important thing I feel like I've ever had the privilege of doing. Yet it was super hard and super disruptive. And I just want to share those thoughts and ideas because I know you guys are seeped in a conversation of how do we make sure we're addressing a growing need in California with what feels like a dwindling set of opportunities and services and people, the workforce, right? And so how do we balance that? And I just want to encourage you to continue to work with Susan and Darcy and Kim Johnson and Michelle Boss and others as we try to look for opportunities like no other state to address this and to think about this quote care economy, both from the perspective of how do we serve those with real needs effectively, adequately, with dignity and with equity, but also how do we make sure we maintain and build up a skilled workforce that is valued and supported, and that these experiences, as I said, I made the quote sacrifice as a resident with a promising known career in front of me as a physician. I know a lot of people don't have the same sets of opportunities necessarily. They're stepping out of careers that are just getting started, that aren't as well prescribed, and they're making important sacrifices and losing opportunities. And how do we make sure we balance all of this? So I suspect and know that this is in the middle of some of the work and issue you all are talking about, and just wanted to share sort of my own experience, encourage you to keep working at this as much as you possibly can, and share your new and fresh ideas, even recycle some of the old ones that didn't exactly stick, because frankly, most of those, they find their time in their day and they can help us make the progress that I know collectively all of you sacrifice your time to contribute to. And I certainly find that a key piece of what our effort is at Cal HHS, and certainly Susan's effort at the Department of Aging. So with that, I'm going to stop. Happy to take a couple of questions, throw some tomatoes my way, share some encouragement or disappointment in your own right, but I can stay for a few minutes if it's not too disruptive.
Well, thank you so much, Dr. Galy. I'm very thrilled that you share your own personal story about taking care of your father. In the meantime, very encouraged by, you saying that please, keep on, giving you some ideas or even recycle some ideas. And that's really wonderful to hear. So I'd like to go back to Barbara so you can continue the Q&A and even answering some questions from the public.
Are we going to have questions from the public at this point? Or do you just?
If any of the committee have questions or comments for Dr. Galy, and then we can do the public comment and then break.
So are there any questions?
I think Andrea has her hand up. Andrea.
I just had a comment. I really appreciate your story, Dr. Galy. And that's why it's really important for consumers to get more term time, because right now we're only getting 1 year and then 1 extra year. And those stories really makes a big impact in relation to the stories, the statistics, the experience, and the caregiver's journey. And so I'm hoping that they'll really revisit the term time in regards to not so much for me, but people that's coming behind me to get more time on a committee in regards to sharing their personal experience, because I think it all come together. And I'm just hoping that the state level really look at that particular bill. I can't remember what the bill number is, but I think it's really important because your story was really powerful. And to know that more of us, have stories either, living with the condition or being family caregiving. So that was one question. One other quick question. It's really important to support the caregiver, whether they're paid or unpaid, in regards to educational training, pay, because they're the foundation of all these efforts. So I'm just hoping that, you guys continue to look at those recommendations. So thank you so much for sharing. It was so powerful, and I love your background. It is so friendly.
Thank you. And thank you for sharing some of the feedback. And we certainly will. I think this aspect of training and providing more tools for people to do the work that they do genuinely from the heart, and with deep connection and relationship with those they're serving and caring for, but to equip with more skills and abilities is always better. And we should find more opportunities to do it for sure.
I can take Secretary Galy. I just want to, another topic, a thread of this morning's conversation was, and Kathy Kelly used the term missing middle. So if you're under the Medi-Cal limit, and I'm not saying that all their needs are met, but there's a lot happening in that space. I mean, the CalAIM program and the staff who've been working on embedding best practices on dementia care, and that's some tremendous progress has been made, and we look forward to more. But now we've got this huge group of folks who are on the other side of that line, right? and don't make enough money to easily afford care and support. So what are we doing for them? So I know there's been work on trying to create a long-term care benefit here in California. I realize how challenging that is, but I just want to urge again, anything that we can do as a committee, or those of us out in the community as advocates to help to move that forward. That doesn't solve all of our problems, but it would be a very important step in the right direction.
I agree with you. I think we have a lot of places to look to support the quote missing middle. There's a number of strategies that we are exploring. Obviously, where that line is drawn, we want to make sure that we're being thoughtful and aggressive with it. If we were to create a benefit, and only one other state, as far as I know, has one, others are looking at it. But we also want to make it a worthwhile benefit. If you're paying into a system to only find that it doesn't actually give you what you hoped for or what you expected, and your extended family is still figuring it out for you, that would also be a major challenge and letdown. So I think all of these ideas are moving, albeit slowly, but we are actively thinking through them and invite you to continue. I know you are, through this committee, through other channels, with Susan, with Darcy, with other people that I have the privilege to work with, to really get us to step up and step boldly into this space. And I think there's a real willingness to do it. Figuring out the details is always the messy piece, but the intent to do that. And the last thing I will say, and we've spent more time on it internally, is just how do we push Medicare, right? And how do we figure out what Medicare's role is in some of this? Because we have so much creative space on the Medicaid side and pushing those limits as far as we can. But the truth is that missing middle all have a thing in common, which is Medicare. And how are we using our own Office of Medicaid, Medicare Innovation to integration and innovation to really think about this piece? So we do have levers. We're trying to think about them all, and are encouraged by you guys pushing us to think more creatively as well. I don't want to. I'm sure if I kept prompting questions, you could keep bringing them, and I appreciate that. But I know you have an agenda and you have public comment and other important people to hear from. So I'll let you all get back to the regular scheduled program, and just thank you again for your passion, your work, and your commitment to working with us to find a better way in California.
Well, Dr. Galy, thank you so much for being here for only 5 minutes, but please come back from time to time, because we love to have you and dialogue with you so we can work together as partners. Thank you very much.
My pleasure. Thank you all. Bye.
So with that, Barbara, do we have any more comments or feedback? Because I did answer the public comment from Diane Puckett on the Q&A chat box. And so for those of you who wants to read what she has mentioned, please, click on the Q&A chat, the box, and then you can see her feedback.
Maybe we could to public comment now.
Yeah, please.
Hello, everyone. This is Carol DeAndres. This is our public comment period. If the public would like to make a comment virtually, please use your Zoom functions and you can raise your hand, and we will go ahead and call on you. We'll unmute your line and call on you. If you're dialing in by phone, it is *9 on the dial pad, and then we will unmute your line. So if you have a public comment, this is a time to give it to the committee. And of course, written comments have been taken through the Q&A function. So thank you very much for utilizing that as well.
Thank you, Carol, for giving that instructions. Do we have anyone from the public wanting to make a comment or ask a question? Okay, let's see. There's one in the Q&A box. Okay. So basically just from
Diane.
Diane. Yeah.
Diane writes,
Something.
thank you, Derek.
Yeah. And thank you, Diane, for your comments. All right, it is 12:11 right now. And so we are going, if we don't have any more public comments, maybe we can take a lunch break right now, and instead of the full 30 minutes, why don't we come back at 12:35, because we have a very packed agenda today. So see you in about 25 minutes. Okay, thank you very much, and talk to you again soon.
All of this morning's presenters. Oh my gosh, that was like a master class in caregiving today. And the way you were all so succinct with your slides, but they were, each one was so meaty. Thank you very much. I took copious notes. I wanted to share, and Barbara, thank you. You actually made a perfect segue for what we're going to talk about here. Maybe as we narrowed the focus, take us out a little bit into the broader context in which much of this activity is happening. So we can go ahead and start with the first slide. Thank you, Rosie. I wanted to just summarize a few of the activities underway at the Department of Aging today. So first and foremost, we do provide the backbone of caregiving services and programs and support and funding through our department. We have the 33 area agencies on aging, all of which receive Older Americans Act funding, Older Californians Act funding in support of family caregivers. And we also support the 11 Caregiver Resource Centers that we thank you, Kathy, and being able to hear about the data from CareNav and what's happening within the network of 11 Caregiver Resource Centers. So while there are 33 and 11, each of these networks support all 58 counties. We also touched a little bit on CalGrows. This is our home and community-based services funding through the end of next year that supports the direct care workforce. And we now have 76 grantees that are providing training to the direct care workforce and to family caregivers, and the stipends program has been activated. I know many of you on this advisory committee are grantees under CalGrows. And we also have other efforts, including the IHSS In-Home Supportive Services Career Pathways Initiative that has been wildly successful and very popular among IHSS workers, again, providing training and stipends upon course completion. And part of that training, in both CalGrows and in IHSS, includes training on Alzheimer's, dementia, and other cognitive impairments. And then we're also very excited about the work at the Health Care Access and Information Department, HCI, as they're rolling out the Community Health Workers program that is now an eligible job type that is funded, eligible for Medi-Cal reimbursement. And within the CHWs, community health workers, there's quite a bit happening around dementia care as well. We also are super excited about our Federal Administration for Community Living grant, CALS Connect. This is in 3 counties currently, Imperial, Ventura, and Marin. And we're partnering with our area agencies on aging and our independent living centers to test a model. And when we heard from our presenter, Hetty, I believe was her name, about needing support after hours, this is part of what we're piloting with CALS Connect, is a one-stop shop for people upon diagnosis and family caregivers to get some intensive services using the care ecosystem model. So right away they get plugged into services, and then they have sustained services for a period of time. And then we're piloting in Ventura County how we might be able to offer that 24/7, which would be the beginning of ultimately someday a 24/7 contact center that CDA dreams of someday. We're also partnering on number 4 with our Department of Healthcare Services on the home and community-based services gap analysis. This was funded in the budget a year ago, and we're so excited about the work that's now underway. We're looking at every Medicaid funded program. So to Barbara's point earlier, that in some ways, California is doing far more under Medi-Cal, definitely more than other states, and actually more than people who are paying privately out of pocket, who are part of the forgotten or missing middle, may not even be able to access a number of services that our state's Medicaid beneficiaries can access. So we're looking at all of the Medicaid HCBS services. This would be adult day health care, multipurpose senior services program, PACE, and many of the other waiver programs, assisted living waiver, for instance. That's on the Department of Healthcare Services side. At CDA, we're looking at the non-Medicaid home and community-based services. So this would be our Caregiver Resource Centers, our area agencies on aging, adult day programs, other parts of our HCBS network. And we're doing this statewide, and we'll be able to see clearly and starkly where the gaps exist. And then we'll have a roadmap to eventually close those gaps. Number 5 is the item Barbara asked Secretary Galy about, is long-term services and supports financing. What more could California do to help people who are in the missing or forgotten middle access home care, respite care, community-based programs, and services and supports that they need to live at home in the community and to avoid or delay long-term care placement. We're very excited to be starting on the Caregiver Equity Roadmap. This is one of our current Master Plan for Aging initiatives. And what we're doing here is we're taking the Biden's, the National Strategy for Family Caregiving that came out a year ago, and we're mapping it to all of California's caregiver programs. And we're putting an equity lens on it, and then we'll be able to step away from that and see where we fall short. So that's something we're excited to be working with UC Davis, Betty Irene Moore School of Nursing on, and it will engage all of our partners, our state partners, our AAAs and Caregiver Resource Centers, all of the nonprofit organizations and the Alzheimer's groups that are supporting caregivers will all be part of that work. And then you heard a bit from Celine about CalCompass. So we are familiar with that, and Michelle Johnson's doing an outstanding job leading that at CDA. We also are pleased that we just issued the first round of funding for Bridge to Recovery. We were able to let out about $20 million 2 weeks ago in support of adult daycare, adult day health care, and PACE centers that need dollars to shore up their staffing and to put in place some mitigation efforts like HVAC funding or expanded outdoor access so they can better serve their population in times of infection outbreaks or what we learned from the pandemic. So those are things happening at CDA. And now I'll move to, let's see, next slide, please. So in the department, you know, our mindset is shifting now, whether it's all of the ARPA funding, the HCBS funding, the COVID funding, or even the hundreds of master plan for aging initiatives. We're now moving moving away from isolated programs and initiatives to more of a system-wide strategy and approach. And so we're calling this our core 4 at the Department of Aging. And it starts with the vision of a no wrong door system. This was key to both the governor's Alzheimer's Prevention and Preparedness Task Force report and the Master Plan for Aging. And we received a federal grant that has enabled us to work across the California Health and Human Services Agency and to enlist other agencies such as housing, transportation, labor and workforce development in establishing a no wrong door governance council for the state. So what we often hear on the ground in the community is, you know, things are fragmented, they're siloed, people get cross-referred, there's not a one-stop shop. And so we recognize that a lot of that starts at the top. It's bottom up and top down. So we're working on that top-down approach by establishing the state's first no wrong door governance structure and council. The second piece in our core 4, and each of these you can see on the screen is tied to a master plan for aging initiative. This month, we're wrapping up a year-long deep dive and examination of our 33 area agencies on aging, our AAA network. We call this initiative California 2030 because we're trying to future-proof the AAA network. Many of our AAAs are celebrating their 50th anniversary this year, and we are trying to project what the needs and demands will be over the next 50 years, and how can we strengthen our AAAs individually and collectively to meet the growing demand and a changing population. It's not just that we'll have more older adults, but we will have more medically complex older adults, more low-income older adults, more diverse older adults, more older adults who are living alone, more behavioral health challenges, more people who are housing insecure, and more people who are impacted by climate change and disasters, whether it's extreme heat or wildfires and other activities. So we'll be putting out a report at the end of this year on our top recommendations on how we can strengthen the AAA network. The third prong here in our 4-prong strategy is, how do we sustain the Aging and Disability Resource Connection program? This is referred to as ADRC. And this is intensive information and assistance and referral that is a partnership between the AAAs and the state's independent living centers. And we've grown this network quite a bit, where we're covering many more counties. We're still in growth mode there. And so we're looking at what is the next iteration of the ADRC model. Once we get them all established, how do we sustain this and embed this in the structure that exists? And then finally, the longest term strategy we have is our data governance and how interoperability strategy. How does CDA interface with all of our community partners, AAAs, Caregiver Resource Centers, adult day healthcare sites, MSSP, ADRCs, and more? And then also, how do we have a public-facing, consumer-directed, these were key goals in the Master Plan for Aging and the Governor's Alzheimer's Task Force. How do we have a consumer-friendly web portal that people can access information and they can enter information and get tailored results for their zip code? How can we have 24/7 support by phone?
live help. So we're looking at call centers, contact centers, and a web portal where we might have some common intake information that gets patched to somebody at the local level. So these are our core four, and it's really building a system that, if successful and when successful, will absolutely support people with Alzheimer's and dementia, will absolutely include family caregivers of all ages. In particular, this data strategy that people can access information if somebody's caring for a loved one in a different part of the state or even out of state, or somebody works off hours and needs to get information, other than 8 to 5, that's our aim. And then at the center of it, this was part of the master plan's LTSS subcommittee report, that everything, all 4 of these domains are person-centered, equity-focused, and data-driven. So it's not just the data strategy that is data-driven. It's the no wrong door system, the AAAs, and the ADRCs. And I think there's one more slide, and then our time is up. Yep, there it is. Oh, and this is just a little bit more on the California 2030 initiative. We just held our final steering committee meeting this week. And we have rich quantitative and qualitative data to share out with you by the end of this year. And these are the 6 areas that we so closely and carefully examined among the AAAs: how they're governed, what the mapping is and how they're designated, what core programs and services are offered, caregiver supports, and health promotion being at the top of the list, key performance measures, funding sources and capacities. What more do we need from the state, from our federal partners, and how can we blend and braid funding streams like Medicare? We heard Dr. Galy say, like Medicaid, like private pay. And then how do we brand and communicate out this network so that it's easier for everyone to understand and identify in their local communities? Oh, thank you, Michelle. And Michelle just put the link in the chat. So that wraps it for me. I don't know. I think that also takes all of our time. So I don't think there's time for questions, but I'm here till the end of today's meeting.
Thank you so much, Susan, and really thrilled to hear all the new developments and all the updates. So thank you very much. And next, we have Dr. Lindsay Stern, who is the interim chief of the Chronic Disease Control Branch at the California Department of Public Health, to provide us with a presentation on BOLD, B-O-L-D, Public Health Programs Grant. So over to you, Dr. Stern.
Thank you, Derek. Good afternoon, everyone. I'm just waiting for my slide to come up. There we go. Perfect. Thank you. Well, as Derek mentioned, my name is Lindsay Stern. I am the section chief for the Alzheimer's disease program, and we are housed within the Chronic Disease Control Branch, where I'm also serving as the interim Chronic Disease Control Branch chief, and we are within the California Department of Public Health. Next slide, please. So today I'm going to give you all an update about our California Healthy Brain Initiative work and a BOLD update. So this past spring, the CDC released a notice of funding named BOLD, Public Health Programs to Address Alzheimer's Disease and Related Dementias. This funding is supported by the Building Our Largest Dementia Infrastructure, which stands for BOLD, for Alzheimer's Act, Public Law 115-406. The California Department of Public Health Alzheimer's Disease Program applied on behalf of the state of California, and we were excited because we were notified this summer that we received funding. We're thrilled because this is the first time that California has been awarded under the CDC BOLD program awards. So awardees were funded under one of 2 different components. The first component involves capacity building for the first 2 of the 5 years, followed by 3 implementation years. And due to California's robust California Healthy Brain Initiative infrastructure, we are funded under component 2, which is funding for 5 implementation years, beginning this September 30th of 2023 through September 29th of 2028, to conduct Alzheimer's disease and related dementias activities in line with the CDC's strategic plan and roadmap actions. So through our notification of award, We were funded $400,000 annually for statewide work that will, one, increase awareness and understanding among the general public, providers, and other professionals of Alzheimer's disease and related dementia topics corresponding to primary, secondary, and tertiary prevention. And secondly, to address the social determinants of health, to achieve health equity goals, including but not limited to the improvement of community and clinical linkages among healthcare systems and existing services, public health agencies, and community-based organizations. So as noted in the map pictured, the CDC distributed out about 43 awards nationwide, and 22 of them were new awards and 21 of them were refunded awards. And California was lucky that we are part of the new 22 awardees, and we are part of 30 that were awarded under component 2. So next slide, please. To address Alzheimer's disease and related dementias at the local and community level, the Alzheimer's Association and the Centers for Disease Control and Prevention developed the Healthy Brain Initiative state and local public health partnerships to address dementia, the 2018 to 2023 roadmap. It's also referred to here as the Healthy Brain Initiative roadmap. And most recently, it was updated and the 2023 to 2027 roadmap was released to advance cognitive health as an integral component of public health. The Healthy Brain Initiative roadmap outlines how to promote cognitive health, address cognitive impairment for people living in the community, and help meet the needs of caregivers. So overall, there are 4 overarching goals of the initiative that the projects work towards, and they include utilizing data to measure and evaluate the health status of populations to identify and resolve health issues, while also assessing the effectiveness, accessibility, and quality of healthcare services and programs available in their counties. 2, engaging and educating community members about brain health and cognitive decline, and strengthening policies and mobilizing partnerships to support health efforts and find solutions. And lastly, building a diverse and skilled workforce of public health and healthcare professionals who are knowledgeable and reliable sources of brain health information and ways to inform those they serve, including caregivers. Next slide, please. So utilizing the aforementioned Healthy Brain Initiative roadmap from the CDC, California conducts the California Healthy Brain Initiative project, which implements the roadmap at a local level via local county health departments. Therefore, the funding received through CDC's BOLD Award will continue to support the California Healthy Brain Initiative's ongoing work. For historical context, the Alzheimer's disease program received state funding from 2020 to 2022 to award 6 local health departments to pilot the Healthy Brain Initiative work in California. And those counties included Los Angeles, you can see here on the map, Los Angeles, Placer, Sacramento, San Diego, Santa Clara, and Shasta counties. And the pilot was so successful that through the 2022 Budget Act, our program received $10 million to run the Healthy Brain Initiative project for a second time. So in 2023, we were able to award up to 12 local health departments to continue and expand the California Healthy Brain Initiative work through 2025. We plan to continue to fund the 6 pilot local health departments for a second phase of work and intended to fund an additional 6 new local health departments through a competitive request for applications process. And with the addition of the CDC BOLD funding, we were able to actually fund 7 newly funded local health departments to conduct California Healthy Brain Initiative work, which is really exciting. The renewal contracts with these 6 county local health departments, they'll continue to work on sustainability through partnerships by engaging a local coalition or advisory committee, and development of strategic plans to monitor and evaluate their continued success and reach. And then in our current second phase of the California Healthy Brain Initiative, we look to lead with equity. Everything we ask projects to complete will be with a lens of health equity and tailoring the work to the communities of greatest need within their respective counties, and incorporating more policy, system, and environmental change at a local level, increasing sustainability, building partnerships and infrastructure to do Healthy Brain Initiative work more long-term, and fund rural projects. So addressing the need of rural counties with limited access to resources and specialty services. And from this first pilot project iteration, we also identified several lessons learned and best practices to inform and improve our program's effectiveness as we continue to expand our work with the newly funded 7 local health departments, which include, from the map you see above, Alameda, Butte, Monterey, Orange, San Luis Obispo, Siskiyou, and Sutter counties. So the Alzheimer's disease program developed a best practices document and shared that with the 7 newly funded local health departments. And these best practices include building sustainability through partnerships, expansion to rural communities, implementation and growth of the Healthy Brain Initiative Train the Trainer, it's a mentorship program, dissemination of the California Healthy Brain Initiative Best Practices Toolkit, and finally, development and implementation of strategic plans to monitor and evaluate the success of their proposed work. So the expected outcomes of our 7 newly funded counties include conducting a community needs assessment, integrating dementia into their programs at the local health department level, and focusing on partnership building to address sustainability. So the funding received from the CDC Bold Award not only supports and expands our ongoing work, but will continue to do so in future years. Next slide, please. In the Alzheimer's disease program's Bold application, we identified our existing statewide Alzheimer's Advisory Committee as our coalition, and per Strategy 1, as outlined by CDC Bold funding's requirements to maintain a statewide coalition, the Alzheimer's disease program outlined the following activities, which include attending these quarterly Alzheimer's Advisory Committee meetings, presenting quarterly to the Alzheimer's Advisory Committee meeting on our statewide and local efforts to advance the California Healthy Brain Initiative work, and then also facilitating partnerships, building with our other statewide partners within the committee, including the Department of Aging, Department of Healthcare Services, our California Alzheimer's Disease Centers, and our clinical experts at academic institutions who are conducting Alzheimer's disease and related dementias research. So through the California Health and Brain Initiative work and funding received from the CDC Bold Award, the Alzheimer's disease program looks forward to continuing to expand the great work that we are doing statewide to implement the 10 recommendations outlined by the governor's task force, as well as advanced strategies related to Alzheimer's disease and related dementias in the master plan for aging. Next slide, please. I think I have one last slide. So thank you all for your time. Unfortunately, I won't be able to stay for the Q&A session at the end of today's meeting. So if you have any questions, please feel free to reach out at alzheimersd@cdph.ca.gov. Thank you.
Thank you so much, Dr. Stern. And glad that you can join us now out of your very busy schedule. So next, we have another segment on looking at the priorities from our August meeting, and that is the different opportunities that we'd like to present to Dr. Galy for his consideration. And so as a very quick recap, last time at the end of that discussion, we focused on several high-level topics, and that is high quality care, care costs, data and awareness, collaboration, and caregiver support. And I'd like to thank Michelle for really providing great staff work, helping me and Dr. Wayne Caniel to be able to come up with some additional suggestions that Dr. Caniel will be leading the discussion in the next 20 minutes or so. So with that, I'm going to ask Wayne if you can start the conversation. Thank you.
Great, thank you. Well, as Derek said, we had reviewed the NAPA and the RAISE plans last session in August. And we identified opportunities for California to further our efforts in advancing the care of people with dementia and their caregivers. I hope you had a chance to review the draft that we had sent, but I'll walk you through these at this time. Do we have the slides up? Michelle, do we do that, Michelle, or?
We were not going to show slides for this part, and I'm going to drop.
Okay. No, that's okay. Yeah. So as Derek said, we focus on the high quality care costs, data and awareness, collaboration, and caregiver support. And so for high quality care, I think all of us know here, and I'm in the healthcare system where, you know, sometimes we feel like we're not doing enough. And some of the things that we are recommending here are things that I hope will provide that perception that we will be providing quality care. I think, so the first one is engage healthcare settings outside of primary care and educated other providers to increase early detection and sensitivity to the care needs. And that is including communication strategies of persons living with dementia and their caregivers. We have the Dementia Care Aware to help us with early detection in the primary care setting, but we know that there's a lot of entry points in the health system where the care could change if the rest of the healthcare system staff are not able to communicate with somebody with a disease, or even be able to provide some tips for the caregiver as they're taking care of their loved ones with dementia. Expand support through CalAIM and DCA, so Dementia Care Aware, to help healthcare system develop tools, trainings, and referral systems for all threshold languages and cultures. So we want to make sure that I think we all in the morning we're talking about making sure that all of our information and resources are sensitive to different languages and cultures. Pursue equity and comprehensive care, including pharmacological and non-pharmacological support. So yes, that we're talking about all the different medications that are out there, and also non-pharmacological support that's already there. Sometimes family members would have to pay for certain caregiver trainings that really hopefully will be more affordable for all. Increase in intensive discharge planning, caregiver assessment, and post-visit follow-up in emergency departments, skilled nursing facilities, subacute, post-acute care, and hospitals. We all know that once a person is discharged from the hospital, that if they don't receive enough information to be able to care for their loved ones, that likely has a worsening of the confusion or other associated symptoms with dementia, it makes it more challenging to care for them, and and then the patients and the family members are then going back to the folks that discharged them. And if we're able to help with this, this will help the person with dementia and the family member. We recognize the care costs, right? So the three of our recommendations here is establishing California voluntary savings accounts for long-term care, develop and launch robust long-term services and support benefits, and expand on affordable respite benefits for caregivers. And I think the folks in the morning kind of talked about these things already. And then just a summary of the data and awareness, fund an annual statewide public awareness campaign, including information on health and community supports, and focus on caregivers. And that the CDPH Alzheimer's Report 2022 need for regular updates, including more detailed data on a county level on people with ADRD and caregivers. Strengthen data collection to identify cultural and socioeconomic needs of persons with ADRD and caregivers, including those who are in-house, Black, Indigenous, and LGBTQ, and other communities. And share CalAIM data on enhanced care management and community support. So learn from this information, and make breakfast. I just learned that this morning, that you call it breakfast. I was going to say BRFSS data more user-friendly and available. And then as far as collaborations go, we are hoping to initiate collaboration with state agencies and state-funded organizations involved in dementia risk reduction issues outside of healthcare. You heard some of these today as well, and I think we see an opportunity to increase that collaboration even more. Expand on healthy brain aging and BOLD to all interested counties, and you already heard just before this about these efforts. Incorporate race indicators of success into the master plan for aging, and explore opportunities for international research collaboration in dementia care, dementia awareness and care. Lastly, of course, but not the least, the caregiver support. We should be able to incorporate family caregiving into planning, into local communities. Ensure that providers identify family caregivers in the diagnostic process and include them in the future planning. That this is something that should be done for every single person, and I don't see it done all the time. Expand family caregiver protections and access. We all saw the data on caregivers this morning. We need to include a caregiver assessment requirement and caregiver-related quality metrics in CalAIM. And finally, include caregiver education and support as an additional community support under CalAIM. So these are the recommendations we prioritize. Would love to hear your comments on these. Any questions first, and then yeah, would love your feedback on how we prioritize our recommendations.
Hey, Wynn, this is Barbara. So can I just clarify a question?
Sure.
Are you presenting, first of all, thank you guys for pulling this information together and presenting it this afternoon. Is the question on the table whether we want to put all of these forward to the secretary in our letter? Or is it a different question that we're?
Go ahead, Derek.
I think when we talk to Michelle, it's important for us to get buy-in from our members at a public meeting so that we can all either concluding with consensus that, yeah, this is the whole list we want to present to Dr. Galy or, else. So Michelle, maybe you want to clarify if that's the expectation.
Yes, so last, in August in our meeting, we didn't have enough time to kind of have a full discussion on the recommendations and the opportunities that were presented. And so before we submitted this whole batch to Dr. Galy, we just wanted to make sure that you all had a chance to weigh in if folks were comfortable with these being shared, if people wanted to share fewer or all of them. And so we just kind of built this time in today to be able to wrap up that discussion so that we can pass on what you wanted to Dr. Galy.
Can I add something as well? So we, as you know, I think not all of our recommendations will probably be taken into account. So we wanted to make sure that we highlight our priorities on the top, recognizing that, yeah, they're all important, but we prioritize them accordingly.
I just wonder if we want to prioritize within this those that the secretary has purview over, because some of these I'm not sure about, like establish the California Voluntary Savings Account for long-term care. I don't actually know where that would live in state government. So I don't know what you think of that. And I mean, does the order matter? Like, I mean, we just had our whole conversation today about caregiver support, kind of makes me want to put that one first.
Not exactly, actually, it's way before that. I think Wynn and I felt very strongly that, this is a good way to capture some of our discussion at our last meeting in August. And so it's not basically tailored to what our agenda looks like today.
Right.
Yeah.
And I think that first one is acknowledging, yeah, there are already a lot of support out there, but not enough, especially for the middle class that we talked about this morning. And that is a way, and I think this is one of the things we actually recommended at our Alzheimer's Prevention and Preparedness Task Force, right, Susan? So it's one of those things that it's just kind of sitting there right now, and hoping that there's some movement there.
I really like the Secretary's comment about Medicare. I mean, he is spot on, but that is a federal program, which is why we don't talk about it as much at the state level. It's very difficult for us to influence that, but you know, we all know the limitations of Medicare, right? What it doesn't cover, people thinks it covers. Well, it could cover those things. That's a choice, right, of our federal government. So I guess there's really, again, because we're a state advisory committee, I don't know how much we could ever say about Medicare, but it is a huge factor in so many of, certainly the high quality care issue and caregivers. But we don't usually talk about it as much. I don't know.
Susan will be sitting at the national level. Speak for us.
I know, which is so fabulous. That was like an early Christmas present when I heard that news. That's just really wonderful that she will be there as an advocate. I don't know. This is just like, if there are ways for this, I just want to support that work, I guess is what I'm in a bumbling fashion trying to say.
I have a comment actually to add to that, and that is that the person who's responsible for the mental health side of Medicare, developing more reimbursement channels for mental health providers and encouraging, she is a colleague of mine and a friend, and she was actually out here recently visiting and talking with myself and others at Stanford in particular, but also some of the other local major medical centers, about how could they expand Medicare coverage, this exact topic we're talking about, Medicare coverage to include more mental health care for the patient, the person with dementia, because as we've heard, they have their problems too, often depression being one of them. But the caregiver in particular, because their caregivers are typically not included. When the patient is given the services, the caregiver is often not included in any way. The caregiver is not assessed. There's no questioning of what might the problems be and what kind of help do they need or want. They're often, as I said in one of the slides, the hidden patient. So anyway, she has a lot of initiatives in mind. And I think would be very open to further discussion with this group, and to Susan, with Susan in particular as the representative, but you know, hearing from the group, from this committee, as to what our thoughts are for expanding mental health coverage for caregivers in particular.
Dolores, thank you for sharing that. And I think we should highlight that actually in the caregiver support part of just add some language into some of those bullets with regards to what you just said.
But I'd be happy to make an introduction, you know, provide some link. So, you know, oftentimes that paves the way a little bit for further dialogue. She does visit out here fairly often because she has a daughter in graduate school at Stanford. So it could even be possible to have a face-to-face meeting.
Thank you. It looks like Susan has her hands up.
Yes, if there aren't other committee members still that haven't spoken yet, I was encouraged by Secretary Galy's comments around, you know, the role and influence of Medicare, and you know, pointing to our Office of Medicare Innovation and Integration. So we have been having some conversations with them on the behavioral health side, and I think there's an intersection here. And you know, thinking of your list, you did just a great job presenting all of those items. The part about hospital transitions. So, you know, I'm just thinking in the master plan for aging, we have the geriatric emergency departments now that are taking hold around the state. We have the age-friendly health systems. And then, you know, if there's a priority around, and I know the Alzheimer's Association has great data on emergency room utilization in California and hospital readmission rates. So there might be something that's around that point of contact that we might look at around hospital admissions, ER use, and discharge planning, because some assets are starting to line up there, and that is more in the Medicare space.
Great. Anyone else?
Well, I guess I'll just put in another plug for behavioral health and to be called out specifically, you know, when looking at the summary, I didn't see that.
Oh, that's what I mentioned earlier, that you added, that we would like, I would like to make sure that we add that verbiage in there. Thank you. Yes. Celine.
I was just wondering, you know, all of the non-pharmacological supports you're referencing, because I think some of those might need to be defined and supported because they can come from different systems of care.
Mm-hmm. Yeah, good call. So some of these are obviously intertwined. So that's why we put the priority on the top as high quality care, because that's all quality care for the patient, for the caregiver, for the system to learn to be able to provide the service and care that hopefully will be embedded in all the programs.
Andrea, your hand is up.
So are we still talking about the recommendations?
Yeah.
Okay, so just a quick, I just want to first thank everybody on this committee in the state of California. You guys are doing such a wonderful job, and it's a privilege to see from the inside of the work that's being done. So when I'm out, you know, talking to people that's living with this condition, I can contest to some work is being done, and that you all are looking out for patient-centered care. So I just wanted to let you know that I'm honored to be able to hear this information. So in regards to caregiver support, just, you know, for us to continue to think about the pathway, I had a chance to meet Dr. Gonzalez. I go to Chaffee College, and I take usually 1 or 2 classes at the community college every semester. And she was there, and she talked about how the pathway in regards to caregiver, they're partnering up. They're actually working along the committee or along this particular project to make sure that that pathway is happening. So for unpaid caregivers, or, you know, caregivers on a professional level, they do have that pathway, because right now there's more work and not enough caregivers. And if we don't make it enticing, or we don't make it where they can bridge into another career, it's going to be really hard. We're already having a tough time having caregivers and quality caregivers, because they're burnt out. They're working multiple jobs. And so I just want to tell you from a professional caregiver and a person living with this condition, how important it is to keep the enhanced career pathway is part of the recommendation, because it is so needed. And there are people out there that's willing to partnership in regards to this particular recommendation. And I just want to say it's important, because looking ahead 3 to 5 years from now, if we don't really take this seriously, we're going to have an even bigger issue. So thank you guys for hearing me and hearing other people, to make sure that we address this, because we're constantly talking about equity, and equity is giving folks a chance to advance themselves on an academic level as well, so that they can provide quality care, and they have the opportunity to go to school if they choose to. So, that's all part of equity. So that was my plug-in. And also I want to let you all know, because I have a caregiver and I see a lot of caregivers here, especially when it comes to IHS, and the pathway, the career pathway is so successful. Many of the providers can't even get into a class. So it looks like they have added more vendors to make sure they have more classes available, because right now either people can't get in, the classes are full, or there's not enough vendors. So it is really going very well. And I'm just telling you from a person living with this condition that what you all are doing and taking the time and putting your heart and soul into this, it really matters.
Thank you, Andrea. We have 2 minutes before the end of this topic. I think we might need to have a vote on this, right, Michelle? Am I correct?
Yeah, I think if you might want to just vote just to make sure you get a poll of the group if they're comfortable with putting these forward with the adjustments that.
Sure. So I think we do have a quorum, because when I did the head count, and we have 1, 2, 3. We have 9 out of 13 members of the advisory committee membership present today. So may I have a motion from one of the members, who basically will allow us to adopt this revised list of priorities?
I'll motion.
Thank you,
Second.
Barbara.
Second.
Thank you. And Dr. Mobley, you have your hand up.
No, I was just seconding the motion.
Thank you so much. Any further discussion on this? Right, hearing none. All those in favor signal by saying aye. Raise your hand, please.
Aye.
Okay, all those opposed? Hearing none. Okay, the recommendations will be forwarded to Dr. Galy. So thank you so much. Well, next topic is also very important, because we need to have updates on the legislation affecting Alzheimer's disease and related disorder and family members, caregivers, so that we become more aware of what we need to advocate for. And so the next segment basically will have Barbara McClendon, who is actually from the Alzheimer's Los Angeles, and also Eric Dowdy, VP of the Alzheimer's Association, and he is focusing on public policy. So why don't you two just take it away?
Derek. So I guess I'm starting. We presented, I say we, that was Jared, and now it's Eric, but it's, we did talk through, I think most of what we're going to share with you today when we met in August, but now we are on the other side of a completed legislative session. So go to the next slide. I am going to cover some of the bills that were caregiver bills, and until very close to the end of session, we were very optimistic that a lot of these were going to pass. And actually, this is a topic maybe for a future meeting, because we've had internal conversations about the paid family leave program, and I've talked with our care counselors, and how many of our families even know about it and access it. I think it's pretty small. Most of the people who take advantage of the program are people who have had new babies or adopted children. So we're actually going to create a fact sheet to share with our families, so that we can try to encourage people, because I do think this is a very important support for caregivers. We would like to see it expanded out and easier to use, which is what some of this legislation would have done. But as you can see, this piece of legislation in particular, allowing expanding who can access the paid family leave program to provide care, ended up being held at the request of the author of the bill. It's now a 2-year bill. What that means is the next session that begins in 2024, at least theoretically, there's a faster path to passage for a bill that has become a 2-year bill. Next slide. So again, a couple of bills that did pass the legislature, but then were ultimately vetoed by the governor, which again was a bit of a disappointment. One, AB 524, related to preventing employment discrimination against people who are caregivers. And then the second, again, making some changes to the paid family leave program to make it easier to use around, no longer requiring people to use vacation time, expanding how many individuals or family members could be accessing the program in order to provide care for a loved one. But again, both of these were vetoed. Next slide. And then we have some bills here that were signed by the governor. Again, SB 616, also a really important bill for caregivers. The original would have expanded sick leave accrual from 3 to 7 days. That got negotiated down to 5. But this would require 5 days of accrued sick leave for people working in the state of California, which actually makes California somewhat of a leader in this space. Next one, related to expanding the nursing home residents' Bill of Rights to include the right to receive information on psychotherapeutic drugs in order to consent or refuse those drugs. This one did also pass as well. And then finally, at least I think it's finally for what I'm covering, was the passage of the healthcare worker minimum wage. So this is a complicated piece of legislation. It is spread over multiple years, 3 years. There are different timelines and different pay bumps for different healthcare settings and sizes. I'm definitely not going to wade into all of that. I will just say that on Andrea's points about not having enough people to provide care, particularly in the IHSS program, we are very concerned that that is only going to be exacerbated because other healthcare settings will be paying people higher wages, at least in part due to this piece of legislation. And so I do think that's going to put even more pressure on being able to access or find care workers. If you are eligible for IHSS, if you've got a family member who's ready to go to provide that care for you, that's one thing. But if you don't, and so now here we're also talking about people who live alone with a dementia. I just think there could be a lot of factors coming into play here that could make that landscape even more challenging. And I think that's my last slide.
Thank you, Barbara.
Yeah.
Eric, go on.
Great. Thank you, Derek. Thank you, Barbara. Just wait for my slides to show up. And if we could just skip, I think there's a vision and mission, we can just skip to the first bill. And great. So this is AB 21. I know we updated the committee on this last time, but this is a bill that would have updated the training requirements for law enforcement officers. Unfortunately, this is a 2-year bill and it doesn't look like it's going to go into the second year, but we are still working on this issue. And actually we've engaged with the Commission on Peace Officer Standards and Training already to update their curriculum without legislation. So that's already occurring. And we do have staff in the LA area working on that. So although the bill will not be moving again, we are still working on this issue, outside of the legislative process. Next slide. And this bill deals with this committee. So this is, again, another 2-year bill. It was held in the Appropriations Committee. Just a reminder of what the bill will do. It renames the committee to the Alzheimer's Disease and Related Conditions Advisory Committee rather than disorders. It expands the committee from 14 to 21 with a maximum of 25. And we are removing some stigmatizing language such as suffering from to living to or living with. And then it removes term limits for members living with dementia. And that amendment has not actually made it into the print version of the bill, but it is anticipated when we do reintroduce the bill next year. That will be included. And then also just a reminder, it is adding more voices to the committee. So we'll have local health jurisdictions, we'll have first responders, a consumer organization, the California Commission on Aging, the primary care physicians, and 2 ex officio non-voting members appointed by a senator and an assembly member appointed by their leadership, and then also 4 members appointed by the HHS secretary. And just I hinted to this a little bit, but this bill will not be the same next year. We do need to reintroduce it with a new bill number. So Assemblymember Aguiar Curry's office has already committed to doing that for us. So when you look for it next year, we'll have a different higher bill number and it'll include all the amendments that we were just talking about. And then the next slide. This is our Alzheimer's diagnostic hubs. This is another 2-year bill focusing on the CADCs, so the California Alzheimer's Disease Centers, to really hone in on some diagnostic work, which we know is critically important as we have new therapies coming down that really are going to require early diagnosis. So trying to ramp up the CADCs as best we can. So as you may recall, they are mandated to do diagnostic services, research, training for individuals and families impacted by Alzheimer's, and then also training of health professionals. And what we'd like to do is move the Dementia Care Aware program under the CADCs, as we think they're very appropriate to expand the model and give us a better reach throughout the state. And we are exploring funding options for that. And I will notice there's a typo on the right side. That's a carryover from the last slide, so we can ignore that. And the next slide. And this is just a list. I won't go through all of these, but as Barbara kind of alluded to, there's a lot of 2-year bills, some that were gutted and amended, and others we need to work on next year. But I think the one I want to call out is the Reyes bill. That's the AB 820. That will need to be harmonized with our advisory bill, whatever bill number that turns out to be. So there is a little bit of overlap, but we'll be working with the Commission on Aging and Assemblymember Reyes's office on that. And I'll just leave the rest there for your reference. If you do have questions, if you can skip to the next slide. My email address is there. And just feel free to reach out with any questions. I'd be happy to provide more detail on anything.
Thank you. Thank you so much, Eric and Barbara, for giving us some updates on legislation. And as I mentioned before, it's indeed very important for us to keep apprised of what's going on. So we'll continue to be advocates for whether they are our loved ones, family members, or whether they are our clients or participants. So we actually have 5 minutes for question and answer with Barbara and Eric. So anyone from the committee who would like to raise your concerns or questions? Andrea, you're next.
Okay. Thank you guys for really advocating for AB 387. That term time, it really would make a big difference to the new committee members coming in, because from my perspective, as a consumer with cognitive limitation, it takes almost a year just to understand the process, of the recommendations, passing bills. I mean, I'm just really getting comfortable understanding this whole process, and to limit the term for the people that's the most important. We're like the soil, and then the other priority is like the tree and the branches, and you need the soil. You need it all, but you need the soil. And so I'm hoping that the new people coming in, and I know they're going to be fantastic, the turn time should be looked at, because some people may want to serve 1 year and they're going to be good with it. And then some may want to do 2 years. So I'm just asking you all to really push that in regards to, from a perspective of a person with lived experience, because it does take time to just understand this whole process.
Thank you, Andrea. Any other committee members who would like to make a comment or raise a question? Okay, hearing none, what about the public? Any questions from the public? Right, I think we can move on to the next topic because we have another segment for public comments right after this. So this is a time for us to finalize the recommendations and items for Secretary Galy. So let's see. So Michelle, are we back to the public comment first, or are we going to finalize the recommendations right now?
And we are going to follow the flow of the agenda, and I believe the next thing is the recommendations. So
Good.
go back.
Great, thank you. So anyone who would like to make some suggestions? Items that you would like to bring to Dr. Galy?
So Derek, I know we talked some about the gaps, sort of from all of that whole long conversation. I mean, like I have a whole bunch of them written here. So, but it just seems like in some way we should capture some of that, and that should be in, because I know we're sending forward what came from our conversation in August, which covers some of it. But I do think it would be worth having a section of the letter that specifically focuses on, kind of takeaways from our whole morning presentation. So I don't know how best you want to, I mean, I can say things now. I know I said some things during the meeting. I can email this to you, Michelle. I don't know quite how you'd want to.
Yeah, if you could email that. I was capturing them as we went, but if you could email, then I could make sure we caught everything listed as the gaps and get the included. Thank you.
Great, I will do that. Thanks.
Thank you, Barbara. Anyone else?
Would you like to put up the public comment slide and remind people how that they can participate if they would like to?
Yeah, sounds good. Yeah, please do.
Okay. Great, thank you. This is our second public comment period. If attendees would like to make a comment to the committee, you may use your Zoom functions and use your raised hand function as part of your Zoom menu of choices. If you're attending by phone, you would press *9 on the dial pad, and that'll bring you to the top of the queue, and we can unmute your line. And of course, you can put your written comments in the Q&A.
Thank you, Carol.
Before we jump into public comment, I just wanted to make sure that we capture that there weren't other people who wanted to make any recommendations for what goes in the secretary's letter. We make sure we.
So just briefly, Barbara will send Michelle a list of the bullet points so we can capture that and share with the whole committee. And then we can look at that before finalizing the recommendations.
I'm back delayed, but even within the recommendations that you and Dr. Canio worked on, Derek, I was just wondering, I know we mentioned some special population, but there was so much discussion today about the missing middle, and even Dr. Galy referred to that, and just highlighting that I think is a strong statement for what is outside of the purview of Medi-Cal.
Yeah, that's a great point. Thank you. Anyone else from the committee before we turn to the public for comments? Right, Carol, do we have anyone dialing in or wanting to make a comment?
No hands are raised, so no comments at this time, Derek.
Thank you, Carol. So hearing none, I'd like to, maybe if we can close the meeting a little bit early. So we have a few things before we adjourn the meeting, and number one is for the next year, we actually have a few meeting dates lined up already. So the first meeting is scheduled for February 1st, 2024. For the month of May, actually, we will have that on the second Thursday, and that is May the 9th. And for the third one, we have scheduled that for August 1st. And the last meeting for year 2024 will be November 7th. Barbara also made a very good suggestion that we pick a couple of meetings and to encourage members who can to attend in person. So any thoughts about that? Which month is better than others? Barbara, what do you think?
Sorry, does someone else want to?
I was just going to say, Rosie, can you please advance us to the next slide so we can see the list of dates? Thank you.
So maybe that February meeting would be a good one to encourage people to try to be in person.
Mm-hmm.
And I think, isn't the February one, because didn't we pend the discussion about the older adult behavioral health initiative? We were going to talk about that, but now I think maybe that might be on the agenda for February. So that would be nice to have that conversation in person.
Yeah, I think what it's looking like for February is that the main topic is probably going to be the kind of emergency and disaster preparedness response, because that was the topic that had been high on the list that we didn't get to in 2023. And then also a short presentation on the older adult behavioral health initiative. So that's kind of what it's.
Okay, that sounds great.
Great. Right. So let's do it February unless we have someone objecting. Okay. And also, not to be redundant, this slide also show there's an MPA event on October 8th. It's the California for all ages and abilities. So hopefully members from the committee will be, planning to join as well. Where is it going to be, by the way, Susan?
It will be held at the Sacramento Convention Center where it took place last year. Same venue.
Awesome. Awesome. All right. Okay. All right. I also like to make an acknowledgement and an announcement. So I want to acknowledge the great work of Michelle. Don't want to be a broken record, but she actually has done wonders, which helped me as the vice chair who run this meeting today to go smoothly. So thank you very much, Michelle, for supporting me and also supporting the whole committee. I just can't, thank you enough. And then an announcement is that, I have been holding my tongue for the whole 4 hours, and I'm so glad that Dr. Galy mentioned about the importance of, having Medicare involved in any major new initiatives or venture. I'm very honored and humbled to let you know that I've been named the new regional administrator of CMS Region 9, and I will be starting my job there on December the 4th. I'm very thankful to have this opportunity to work with this committee. I have to check with CMS to see how I can involve with this committee as a member or as a vice chair. But one thing I'm sure is that I can definitely work with you as a federal liaison, being a senior official at CMS, because in my capacity, I need to work closely with the state governments, and California is a very important state government with the contractors, with health plans, with beneficiaries, and all the stakeholders. So I look forward to be working with you in that capacity. I have been taking notes as to what you all mentioned, but I've been holding my tongue because I don't want to just steal the limelight. And I just decide to wait until the very end of this meeting to do so. So glad to have this opportunity to work with you in the capacity as a family caregiver. But I look forward to working with you in my new capacity as the federal liaison, when I start working for CMS as a regional administrator in December. Okay, thank you, thank you. So with that, is actually 1:58. I think we can adjourn the meeting earlier. Okay, thank you for everyone participation.
Thank you.
Thank you, everyone.
you.
Congratulations, Derek.
Yeah, congratulations.
Thank you. Bye.
Bye.
Hey, Michelle, can you stay a little bit?
I sure can.